Good morning, good afternoon, and good evening to all of you digital health leaders from around the world. My name is Stan Kichnowski, and I am the chair of HITLAB, and I am very excited to present to you the February edition of the monthly HITLAB Symposium, where we review all of the digital health evidence from around the world and what's being adopted in digital and what is not, what's working and how it's working. So thank you all for joining us. Really excited to present what we're going through here today. The agenda for hour number one, remember this is your 3-hour digital health evidence overview every month. The last Thursday of every month between 11 a.m. and 2 p.m. Eastern Daylight Time. We've got starting off Dr. Michael Meany from One Small Step, a former Facebook executive who's now helping develop a peer-to-peer platform that will help folks around the world. Then we'll start off hour number two with Divya Verma, who is chair of the Women's Health Tech Initiative and vice president of business development at Accord Pharma. And she'll be talking to Juliana Berman, the head of digital strategy and one of the leaders in the ecosystem. And then we'll be lining up the third hour with everybody listening to and starting off with Tamer Chowdhury, who is the head of data governance at Beringer Ingelheim and managing all of the good things going on there. And we'll hear from him and how that's working out. And then we'll end up the program at 1:45 p.m. Eastern Daylight Time with Jessica Scott. Dr. Scott is the director of exercise oncology program at Memorial Sloan Kettering, one of the leading cancer centers around the world and right here in downtown Manhattan, Midtown Manhattan, actually. And looking forward to this day filled with digital health evidence and what's working for those of you who are buying digital health solutions, investing in digital health solutions, and actually starting and scaling digital health solutions. So with that, we're really excited to kick off the day here today with Michael Meany, the co-founder and the CEO of One Small Step, and excited to talk to him about what we're doing and how we're doing with peer-to-peer counseling in One Small Step. Michael, how are you today?
Hey Stan, I'm doing well. Thanks for having me.
No, I really appreciate you joining, and love to hear more about your background and your journey with One Small Step. Maybe you could start off and tell people a little bit about how and why you started this company.
Yeah, absolutely. I'll start off at an even higher level because some people might be wondering what is the relationship between mental health and cardiovascular disease and why would I be speaking on this? But the stats around here are pretty astonishing. If you have major depression, you're 72% more likely to have cardiovascular disease. If you have phobic anxiety, you are 70% more likely to have cardiovascular disease. Schizophrenia, nearly 100% more likely. And so the relationship between the heart and the mind is so central. It's something that we see in all the patients that we help serve. We're building tools to help identify when people are at risk, and we have to move toward thinking about how to treat the whole person rather than these kind of disambiguated diseases. But my own background, so I'm a technology executive by training. I did my PhD at the University of Cambridge, and I worked on the Facebook Marketplace team for a number of years, shipped products for billions of people. I'm 12 years in recovery from alcoholism myself. March 3rd will be 13 years, but there's no fronts in sobriety, as they say. And so, this platform that I've built, which provides people access to high quality mental health care on demand on nights and weekends, is a fusion of both my sort of personal experiences and my professional practice as well.
That's an extraordinary story. Tell us a little bit about the connection between cardiovascular health and mental health.
Yeah. Like I mentioned, mental health is just such a high risk factor that exacerbates cardiovascular health. So any number of these conditions, depression, bipolar, panic disorder, PTSD, schizophrenia, all of these are risk factors that make someone much more likely to experience and have cardiovascular disease. And then Of course, on the flip side, after you have a cardiovascular event, you're 40% more likely to have severe depression. And so mental health is both a leading indicator of cardiovascular disease and a sort of like post facto one. And basically, all of the patients that we treat, a number of them have cardiovascular disease. What our patients typically experience on nights and weekends is they are elderly, often they live alone, they're on Medicaid, they don't have access to resources. And what that used to mean before our platform is that they would call 988 or call 911, they would escalate and sort of have like a crisis event. Oftentimes ending up in the hospital, oftentimes being admitted. Those are $5,000 to $25,000 events for what in effect is a loneliness problem that exacerbates mental health challenges. And so we have a platform that connects these folks to certified peer support specialists on nights and weekends that have been in their shoes, that are in mental health recovery themselves. Sometimes we do help them identify that they need to go to an urgent care, but oftentimes we just walk them through coping skills, meditation, deep breathing, help them calm down, and they're often able to sort of de escalate, which improves their mental health, but also improves their physical health.
And so when you look at the continuum that we see with mental health these days, a lot of folks are using different platforms, for mental health support. How is your plan evolving to address growing that kind of continuum and differentiating itself to help people with their emotional health and influence, the various types of outcomes like cardiovascular disease?
Yeah, yeah. So I think there's been a lot of mental health innovation over the past 5 years, especially since COVID. The high level things I'd say is that these are still focused on business hours. So like our whole healthcare system is sort of designed around business hours and credentials rather than moments of care and moments of need. And basically, mental health incidents for both severely mentally ill patients as well as general mental health and substance abuse patients disproportionately happen on nights and weekends. That's when people escalate. That's when people struggle with their jobs, with their relationships. And so we extend the non-crisis continuum into nights and weekends because that's what most people need. Most people don't need to go to the ER. Most people don't need to call a crisis hotline on nights and weekends. That's just the only thing that they have available. So we're extending the continuum to the place that it like really really matters. So that's on our human to human marketplace. And then we're building AI agents that are based on actually all of our real life peers that are 24/7 companions for all of our patients. And so that provides them 24/7 support. And we have algorithms that can identify like whether someone is at risk or escalating, and if they need human in the loop support, we route them to that. But in most cases, people are able to engage with the AI in sort of micro interactions that support their mental health throughout the day, and then we'll speak with a human peer at night if needed.
I love that. That's so great to hear. And again, you're used to work for Facebook. You ran product over there, and so really you understand engagement as well as anyone. And certainly AI is the cornerstone of that nowadays, and how to use AI to improve engagement with patients. And do you see that working in terms of signal detection and being able to predict episodes, or even like things like reduce cardiovascular outcomes ahead of time? And do you see AI being able to do that based on what you're seeing within the AI ecosystem right now?
Yeah, such a rich and multifaceted question, Stan. Let me think about. So, I think a few things. We are a long way away from real time AI detection of cardiovascular events, like based on like text input. Just or the work that I've seen, we're not at a place yet where we can identify a like relationship between typing patterns and explicit cardiovascular events. But what we do know, like I started with, is that significant mental health incidents exacerbate cardiovascular disease, um, and what we can tell with our algorithms of like detection right now are like whether someone is stressed or anxious or anything like that, and these are long-term predictors of cardiovascular events. So in that way it is helpful signal toward this. I'd say, let me speak on the skeptical side now for a second, because my co-founder who did his PhD in mental health AI, he just published his research on Archive, Ian Steenstra, if you're interested in it. So he found that there are two ways that AIs actually exacerbate mental health issues. So everyone's heard of sycophancy, which is when the AI kind of encourages you to, it's it's a sycophant, right? It's kind of like a yes man, right? And so for people who are depressed, that isn't always helpful. And then he identified this other novel observation of co-rumination. And so the AI will just continuously sort of like co-ruminate with you, and that can actually exacerbate your mental health issues as well. So when we're building our platform, we focus a lot on sycophancy and co-rumination to minimize those, because that can actually make mental health worse, which then in turn can make cardiovascular incidents worse. But as far as kind of having signal processing in real time that can predict like a heart attack, I'm not familiar with that work, and I don't know that we're there yet.
Okay, great. Yeah, if you can drop that into the chat box or send it to us, we'll send it out to the audience so that everybody can get a hold. I love the fact that there's a PhD now in digital behavioral medicine, whatever you just said. That's fantastic. So again, last question, and I'd love to talk to you about this all day long because it's so important, especially given the cardiometabolic issues the country's having right now, and the heart attack epidemic we've got going on, the diabetes, pre-diabetes epidemic we have going on. Looking ahead, Michael, where do you see the greatest opportunity for this kind of cross-disciplinary work and integration happening between mental health platforms, telemedicine, AI, and then the overall physical health monitoring to improve cardiometabolic and cardiovascular conditions for patients around America?
Yeah, yeah, absolutely. So I think there's some really esteemed panelists speaking after me, and that have really deep, extensive, and impressive backgrounds in cardiovascular health. And I think they'll probably be the first to tell you that like you can't just treat the cardiovascular symptoms. You have to treat the whole person, and so that's mental and physical health. I mean, it's really kind of like as we move toward this AI world, it's really exciting because we have new signal detection algorithms and platforms that can surface these signals. We can scale resources to support people. But what do people actually have to do to improve their mental health and therefore improve their cardiovascular health? They have to exercise, they have to eat well, and they have to have human connection. These are three things that AI can't do. And so we have to think about ways where our sort of analog human world can complement these new novel technologies to ensure that we are using the fusion of them to improve people's health and public health in general.
That's great. Michael, thank you so much for joining us today, and looking forward to hearing great things about one small step going forward. Again, anyone who wants to contact Michael, about his platform and implementing it in different types of employee wellness programs or inpatient rehab, outpatient rehab programs, and others. Please do contact him directly or contact me as well. And with that, we're really excited to hand off to our own Jerry Antamano, one of the managers of all the different HitLab communities we have going on here at the lab. Jerry, handing it off the digital microphone to you.
Yeah, cheers, Dan. Thanks so much. And it's a great way to open up our February symposium, reminding us that the physical aspects of our healthcare are so dependent, or vice versa, our mental health is dependent on our physical well-being as well, as we talk about cardiovascular care. But just as a quick reminder before we go into our next session with our next speaker, that the Breakthrough Alliance is expanding over into Europe. We're holding our second conference in Paris, March 31st, April 2nd. We are looking for speakers. If you are interested in speaking, please visit the link that the team is putting into the chat. If you're interested in speaking at the famous Hotel Dieu, one of the oldest hospitals, if not the oldest hospital in Europe, where the conference will be held. So very exciting there. But from a European health system over to a US one, it's my pleasure to welcome Steve Mayer, who's currently at Fresenius. Steve, welcome to the program. Love to hear from you about your background and your journey yeah, at Fresenius, and also the work that you're currently doing with HitLab now as well.
Okay, great. Thank you. Good morning, everyone. Uh, just a little background on myself. I'm Steve Mayer, over 15 years of healthcare leadership, operations, experience in fast-paced hospital systems. Previously to Fresenius, I ran the busiest ER in New York State for several years until kind of pivoting to, again, another really fast-paced clinical environment with Fresenius and working with chronic kidney disease. So it's been a great experience so far.
No, it's wonderful and great to have you as part of our community, Steve. And we'll delve right into looking at operational excellence in cardiovascular care and acute and chronic settings, which you no doubt have a lot of experience in. And let's talk a little bit about and hear from you about the standardization across the various different settings, and of course where you sit from an operations perspective, and where you're seeing how healthcare systems can better standardize cardiovascular care protocols across acute hospital settings as well as chronic output environments, so that we can have, most importantly, continuity and quality across the board.
Mm-hmm. Yeah, I right now I think healthcare is still organized by location, but cardiovascular disease is continuous. The solution isn't more guidelines, but you need more shared workflows. So every cardiovascular patient should leave the hospital setting with, some type of scheduled follow-up appointment with that office, medication reconciliation done with them, and some type of automatic notification I've seen really help. Say once they're leaving that ED setting, going inpatient, and what have you. When the ED, inpatient, and outpatient teams just operate on a similar pathway instead of kind of separate protocols, that continuity of care and quality, they really improve drastically.
No, absolutely. 100% agree with that. And what operational strategies have you seen that have been most effective in reducing some of the readmissions and improving outcomes, especially for cardiovascular patients transitioning between the inpatient care and also the longer term management that's so important?
Yeah. The one thing with most readmissions, they aren't clinical failures, so to speak, but, I believe transition failures. I think the highest risk period is usually within that first 7 days after discharge. So the biggest drivers that I've seen, especially being in the ER, The medication confusion. You need to have that kind of teacher at the point of discharge. Fluid mismanagement is huge, and no timely follow-up with that patient there. And like the previous presenter, the socioeconomic barriers I think are huge there as well. So what I know I've seen work is, schedule that cardiology appointment before discharge, before that patient is even leaving the facility. A 48-hour follow-up call I've seen work tremendously, and just clear ownership of that patient. When someone is accountable to that patient after discharge, readmissions drop tremendously.
Yeah, no, absolutely. And of course, a lot of those strategies and decision making is really driven by data, especially if you want to make improvements to those various different systems. So how are the performance metrics and real-time data and also dashboards that that may be being used? How are they identifying gaps in that care delivery, and how are you guys turning those insights into more of the frontline actions and actually helping our providers and healthcare professionals operate effectively?
Yeah. Uh, I think, like you said, I think healthcare has plenty of data. It's just sometimes we use it too late. Most of the dashboards are retrospective, so to speak, there, but by the time we review them, the patient has already been readmitted. I think the data only matters when it triggers some type of action there. The some good metrics that I've seen, missed follow-up appointments,
Mhm.
Following up with that patient if there is a trigger that the patient has not picked up their medication. 72-hour ED revisits are a big point, and any rapid weight gain um, in between that heart failure there. I think each metric is definitely needed, but it needs an owner again with that workflow, and just real-time intervention. Not just reporting. I think again just improves overall outcomes.
Yeah, no, absolutely. And there's certainly a high demand, and there's certainly a lot of pressure put on, the workflow and and the staffing in general. Especially in these high demand settings. Are there any specific sort of operational changes? Whether it's to staffing models, whether it's to the training, whether it's to the redesign of workflows.
Mhm.
Um, has any of that had any specific impacts that you've seen on patient outcomes?
Yeah, I think immediately. I think the go-to always is kind of more physicians, but I think it's better team design. I think the chronic cardiovascular care works best when there's a care coordinator,
Mm,
some type of nurse navigator in the process, and just standardize again patient education. I think is huge. If the patient does not know everything that's going on within their care post discharge, that's kind of when everything kind of falls apart. So I think the biggest issue is that many systems treat the patient, but no one manages the patient. So when one team owns that patient longitudinally, the outcomes improve drastically again.
yeah, of course. And then there's also cost, right, as well. How do you balance, the delivering high quality care, especially with those folks that are in that care setting of making sure that we have quality cardiovascular outcomes, and then of course making sure that uh, the site, the infrastructure is sustainable financially.
Mhm. In cardiovascular care, cost and quality align. They're hand in hand. The most expensive care is prevention. Readmissions, ED visits, So the highest value investment is proactive management. I've always kind of been a big proponent of that. So again, some type of follow-up infrastructure with that patient, monitoring and just overall access to care is going to be huge for that patient. So managing chronic diseases, it early reduces, that overutilization, which improves both outcomes and physical sustainability.
No, absolutely. I mean, this has been a great conversation, Steve. I mean, with all the talk around AI and how, AI is going to be changing the way that a lot of these strategies go forwards, especially in chronic care and acute care settings. It's great to hear from you about the human touches that are going on, strategy-wise and stuff. And I encourage everybody in the audience, of course, to connect with Steve. We popped his LinkedIn and website in the chat. So, I think this is really fascinating, Stephen. I encourage everyone to carry on this conversation with you offline as well. But thanks so much for your time and insight, Steve. Great to have you on the program, and no doubt we'll have you back on soon to share more.
Thank you. Looking forward to it.
Wonderful. Okay, great. That's a great way to come into our second session of today's Virtual Health Symposium. And as a quick reminder as well, the HITLAB Innovation Summit as part of New York City Health Innovation Week is taking place this May, first full week of May. The HITLAB Summit will take place May 5 to 7th, with the whole week going from May 3rd to May 8th, so the Sunday to the Friday. And we are looking for speakers as well. So if you are interested in presenting or speaking on a panel, please visit the link that the team is putting into the chat to let us know what you would like to speak about. And moving on to our next presenter, we've got Ravi Kondadadi from pulpdigital.ai, one of HITLAB's newest startups that we're working with at the moment, who will be sharing a presentation with us around the work that they're doing and closing the behavior gap with the multi-agent AI platform that they have at Pulp Digital right now, especially as it relates to cardiovascular care plans. So Ravi, welcome to the program. Thanks for joining us. And I'll hand the podium over to you so you can share your insights with the audience.
Thanks, Jerry. Happy to be here. Let me share my screen quickly. Can you all see my PowerPoint here?
Yep, we can see it. Yep, if you put in presentation mode. Yeah, perfect. Okay, perfect.
Okay. Thank you so much. So I am Ravi Kondadadi, CTO of pulpdigital.ai. So really glad to be part of this symposium here and be able to talk about our product, which is really about closing the patient behavior gap. So let me jump straight into the slides here. So one of the biggest cost drivers in our healthcare system today is patient non-adherence to care plans. So we think that our patients don't understand their discharge instructions. They don't show up for follow-ups. They cannot take their medications properly. And most don't have the health literacy to manage a complex condition like heart failure on their own. So this is what we call as the behavior or the patient behavior gap. So care plans today are static. They ignore comorbidities, health literacy, language, or any other cognitive needs of patients. There is no continuous support between visits. So patients get pretty good care as long as they're in hospitals and clinics, but as soon as they go home, they're on their own. And our care teams simply do not have the bandwidth to follow up with every patient every day. And most critically, there is no behavioral execution layer. So as we all know, EHRs are really excellent at documenting care plans, but there is really nothing about this, what we call the behavior gap, that kind of like give proper nudges to the patients to make sure they're adhering to their care plans. So these two are completely different. Documenting a care plan like what we have in our EHRs versus following up with patients So we are really focusing on that second problem, and that's what we call as the behavior gap. So our solution to this behavioral gap problem is called Care IQ. It's a multi-agent AI platform where we have 4 AI agents that work in concert to help patients adhere to their care plans. So we have a care companion, which is a patient-facing agent that can proactively drives medication adherence, guides patients through procedure preparation, it can track their symptoms and deliver nutritional guidance. It can proactively reach out to the patient, and when it can detect something concerning, like a missed medication pattern or worsening symptoms, it can immediately escalate that condition to the care team. Care nurse is our triage agent. It filters the escalation noise and surfaces only the issues that require real human judgment. And most importantly, it can get better. It can learn over time. But the nurses still stay in control, and AI makes sure that nothing really falls through the cracks. And then we have our care physician, a physician-facing agent that can generate longitudinal summaries for physicians to make it easier to understand the patient's current health situation. And there are no new to screens to open or anything. It's all written directly to the electronic health records. And then finally, we have the caregiver, which is the caregiver facing agent, which activates when the patient engagement drops and brings family into the picture, into the care loop at the right moment. So, and Care IQ can seamlessly work with Epic. So as I mentioned before, Epic handles the clinical workflow, and Care IQ is the operates at the behavioral execution layer. So we operate orthogonally to Epic, and we care about the care for patient in between the visits. I'm trying to move to my next slide here. Okay. So the core component of our platform is what we call MAP. It's a multi-layer adaptive personalization. It's a 3-layer knowledge graph. So the top layer is a global clinical knowledge graph. It includes various like cardiovascular related guidelines, like from ACC or AHA, GDMT protocols and procedure instructions for various cardiac procedures like cardiac cath or MRI and stress tests. So this layer contains no PHI. And then in the second layer, what we call as the institutional layer, where we can have various operating protocols of the institution. We know that different healthcare institutions have different clinical workflows, and they can override some of the global clinical knowledge. So that's where all of the clinical knowledge specific to the institution lives. And then finally, at the last layer, the patient layer, we have all the information about the patient, their care plan information, and any information that we extract from the patient. So together with these 3 layers, the knowledge graph has the complete information about the clinical protocols as well as the patient information, and can generate the right information for the patient at the right time. We also have, in addition to the knowledge graph, we have small language models and reinforcement learning models that I will talk about soon, but all of these 3 together will work towards patient adherence. So you might ask, why small language models? I'm sure most of you have heard about large language models like ChatGPT and Gemini and Claude. But most of these large language models, they have been trained on trillions and trillions of data. And none of these models are specifically trained for healthcare. And they're huge. They have trillions of parameters, and they're really hard to control. What we really need in healthcare setup are small language models that can be fine-tuned. So we've developed small language models on hundreds of thousands of clinical conversations, especially in cardiology and oncology setup. So small language models are safe. They are easy to control. They can be completely set up in an institution's VPN. So the data never leaves out of their VPN. The institutions have complete control of on their data. And with graphs and small language models, we can completely control hallucinations. Hallucinations, as you know, is one of the biggest problems with large language models. And in healthcare, there is no room for hallucinations. We cannot give a wrong guidance to our patients. So that's one of the main reasons why we chose small language models. They can be better aligned with protocols. They have they can be much faster than large language models because we are not really going into the cloud, and they can even be deployed on the edge on a patient's mobile device if required. Um, and then the last component in our MAP platform is really this reinforcement learning engine. So, so reinforcement learning models can learn on the fly. So any machine learning models are usually trained on a specific training data set, and then they stop learning there. But on the other hand, reinforcement learning models can learn from every data sample. So in our setup, every time this model is interacting with the patient, it can learn from the patient. Like for example, if our map tries to reach out to a patient, to a senior, through a voice a medium in the morning time, and the patient does not respond, it can immediately learn that that's probably not a good time to reach out to that patient. And it can and the same with the tone of the message or the length of the message. So and it also knows about other patient's preferences, and it can adapt based on the patient's personal setup. So basically, it is kind of creating uh, a personal profile, a health profile of the patient, and adapting to that profile and continuously learning about the patient. So using this reinforcement learning, we can do a much better job of uh, helping the patient adhere to the care plan, because we know how to nudge the patient at the right time in the right way to adhere to their care plan. And we trained a reinforcement learning model on a lot of data from 12 different demographic segments. And it can, again, continuously learn from every patient interaction. And finally, we are working with various healthcare organizations to test this product in multiple use cases. So, for example, one of them is pre-procedure readiness. For many hospitals, missed appointments is a big problem. So we are using this platform to personalize these prep instructions for patients for various procedures like cardiac cath and MRI and stress tests. And we specifically understand what the patient needs to do. For example, if patient having a pacemaker needs to bring their pacemaker card to the MRI. Similarly, patients who have any specific dietary restrictions, we can exactly give them the instructions that they need to follow before the procedure, to make sure that they are ready for the procedure. It can also be used in the post-procedure care setup. For example, after a CABG surgery, and it can proactively reach out to them. It's on 24/7, and it can continuously support them with their medication adherence. It can monitor any symptoms and escalate to the care teams when it is appropriate. And we hope that these kind of tools will help reduce the 30-day readmissions, which is a big expense to the healthcare systems today. And finally, most importantly, we believe that an AI like this can help patients manage their chronic conditions. Again, heart failure, diabetes, or any other chronic conditions, because this reinforcement learning model that I just talked about, it can keep the patients active. It continuously learns about them, and make sure that they exactly follow their care plan between the visits, and make the best use of the information that is provided in the care plans. So that's all I have today. Thank you so much. So please feel free to reach out to us. So we're on LinkedIn. We are excited to work with any healthcare organization interested in our technology.
No, that's really fantastic, Ravi. Thanks so much for coming on, and it's really really exciting what you're doing in the healthcare system to change, to make a behavioral change, both for physicians and patients. So looking forward to seeing how you're doing, and of course encourage everybody in the chat to connect with both Ravi and the folks at Pulp Digital and learn more about what they're doing for sure. Thanks so much, Ravi.
Thank you.
Okay, awesome. Fantastic. Well, it was a great presentation there. And as you all may be aware, February is Heart Health Month. And who best to join us than the Director of Non-Invasive Cardiology and Executive Dean at SUNY Downstate Medical Center, a familiar face to the program, Dr. Jason Lazar, who needs no introduction, although I will ask you, Jason, to give us a quick 30-second intro on what you're currently doing over at Downstate. And pleasure to have you on as always.
Thank you, Jerry, and it's a pleasure to be here. Good morning, everyone. At SUNY Downstate, we're looking at chronic disease models as they involve multiple disease states. So it's, from my perspective, the overlap of cardiovascular disease with non-cardiovascular disease chronic conditions. Rheumatologic disease, a whole number of, and my particular interest is the overlap of cardiovascular disease with urologic disorders. And I think that there's a compelling rationale for that.
No, that's great. I think I certainly a conversation for next time, for sure. But I think what you're on today to discuss is something we may not necessarily associate cardiovascular risk with, which is the quality and science of sleep. So definitely love to hear more about the compelling biological mechanisms that links the sleep disorders like sleep apnea and insomnia and so forth to increase cardiovascular risk and what you're saying.
Sure. One of those chronic conditions that I was alluding to is that of sleep disorders, and my group is doing a lot of work in that. In my view, there are three mechanisms that explain the link between sleep disorders and cardiovascular risk: the autonomic nervous system, inflammation, and a variety of metabolic pathways. In obstructive sleep apnea, recurrent airway obstruction leads to low oxygen levels, so-called hypoxia. And it's these arousals which increase the activity of the sympathetic nervous system. This causes oxidative stress, causes our blood vessels to malfunction, so-called endothelial dysfunction, and all of this raises blood pressure and promotes the development of atherosclerosis, fatty lipid deposits within our blood vessels. Chronic insomnia, which a large segment of the population has, also works by the same mechanism: activation of the sympathetic nervous system, increased stress hormone levels, and really insomnia is a major generator of inflammation, chronic long-term inflammation. And it's remarkable that all of these pathways tend to increase blood pressure, make our cholesterol profiles worse, worsen and increase our glucose levels even when fasting, and they predispose us to becoming overweight and sedentary in lifestyle. Then I would add one more sleep disorder, and that is circadian misalignment, such as shift work and even jet lag to some extent, where these circumstances disrupt our normal pattern of metabolic health with our external loads of metabolic demand. And all of these taken together are evidence of cardiovascular stress.
No, those are some really great examples. And speaking of evidence, I know you keep up to date quite a bit with what's going on in the most recent and latest scientific discoveries, and our understanding of how sleep duration and quality, and as you mentioned, circadian rhythm, are disrupting current heart health. What have you seen in sort of most recent publications and papers that are helping to develop our understanding of that?
So, as I said before, multiple lines of evidence have suggested that sleep duration, quality, and particularly sleep fragmentation are all associated with higher blood pressure, higher cholesterol levels, particularly the bad and the ugly cholesterols, triglycerides and LDL levels. And they promote weight gain and, in particular, central fat deposition, the so-called belly fat, the main producer of inflammation in the body. In addition, there's been several large multiple cohort studies that show a U-shaped pattern between cardiovascular risks, such as heart attack, myocardial infarction, and impaired sleep. So, people who sleep less than 7 hours tend to have very high risk. However, interestingly enough, those that have higher sleep durations, greater than 9 hours, also have high risk. So the sweet spot is generally between 7 to 9 hours. And there's a lot of speculation as to why that may be. Maybe people who sleep longer are actually having lower quality sleep. But all of these, sleep duration clearly predicts high blood pressure, heart attack, stroke, and even cardiovascular mortality.
Yeah, no, there's again some really great examples that you can share with us that certainly give us a better understanding as to sort of where that link is. I'm sorry we don't have more time to spend with you, Jason, but I wanted to make sure I ask you this specific question, especially about the sort of future of where this is going with the link from sleep quality and duration to cardiovascular risk. And, branching off the research piece, are there any unanswered research questions about sleep and the link to cardiovascular health that you think are the most urgent for our current academic, scholars and professors and doctors should address for the next sort of 10 years or so?
Yeah, I think I'll leave you with three quick bullet points. Look,
Sure.
it's very clear that impaired sleep is associated with higher cardiovascular risk, maybe even a higher risk for cancer. What is less clear is that whether an individually tailored approach to improving sleep duration and quality is associated with lowering of that particular risk. And I don't think you need very expensive or extravagant equipment to do that. In the age of AI, wearables are now providing pretty good measures of not only the total amount of sleep, but the types of sleep. Deep sleep, REM sleep, and really it's the proportions of light, deep, and REM sleep which may matter more. For me, this is a throwback. This is really back to where cholesterol was in the 1960s, where we had cholesterol and triglycerides, but we knew nothing about the good cholesterol, HDL, and the ugly cholesterol, LDL. So I think in the age of AI-driven wearables, we're going to learn a lot about the various fractions of sleep. REM sleep is associated with emotional and mental regulation, whereas deep sleep really facilitates physical repair. But how these mechanisms that we talked about is also pretty interesting. And third and lastly, it's well known that cellular health impacts aging. And let's break this down to the most basic component of a cell, and that is the mitochondria. That's the structure in each cell which produces energy. And it's very clear that mitochondria produce more energy in healthy people and less energy in those with chronic disease. And recently, it's been shown that poor sleep duration and quality do what? They impair mitochondrial activity. So whether this is reversible or whether better sleep can improve mitochondrial function and therefore slow the aging process and the development and progression of chronic disease states, I think is going to be a fascinating research story over the next decade or so.
No, those are great bullets to leave us with. Jason, thanks so much. I feel like I learn something new every time you come on the program. So, a real pleasure to have you on as always, Jason. And those of you who haven't connected with Jason already, please do connect with Dr. Lazar, who we put his LinkedIn into the chat, and also the Downstate website, so you can find out more about what they're doing right now. But Jason, thanks so much for your time. We know how busy you are.
Thanks very much.
Thanks so much. Okay, wonderful. Okay, great. And if you do want to meet Dr. Lazar in person, he should be at our summit in May. So do keep an eye out for more updates around the program and the event happening in New York City. But we'll move on now to look at women's health tech, actually, and where cardiovascular care through clinical research innovation is being explored with Dr. Mary Catherine George, who you all may know as one of our finalists at our last Women's Health Tech Initiative Challenge, and one of our newest Women's Health Tech board members, Wayne Catherine, who will be conducting this interview. Wayne, welcome to the program, and I'll hand the reins over to you.
Okay, great. Thanks, Gary. And I'm glad I had my 7 hours of sleep last night as we move into.
I wish I could stay the same.
Well, as we move into research, as we continue to move into research, and Dr. Mary George, it's so pleasure to have this conversation with you today. Maybe before we start our rapid fire with questions, you may want to give us a little just overview of what you're doing, and
Sure.
and I love your LinkedIn title, visionary improvisation researcher. So please give us a little bit of what you do, and we get started.
You know, I came to research and have a real passion for research because I feel like it's the best way for us to get a sense of how to understand us as a whole being. And that's what I think the next 10 years is going to truly launch us into a deeper way of having this depth of knowledge that we've never been able to obtain, which is about behavior. I'm a health psychologist by training, and basically I love that our research designs are changing our ability to go and help patients understand their behavior and how that potentially can influence their biological responses is a huge field that fascinates me. I work with something that is on the premise of self-hypnosis, which is what I am doing for chronic pain. And truthfully, I help others design clinical research studies so that we can take these innovative ideas and somehow move them forward to bring them into our patient populations that are poorly served, actually. And it's the innovation that we're needing to bring to those really challenging populations that are really suffering from cardiovascular disease. And we're going to, I think, through this innovation of research and implementation research, truly find a way that we can start to develop this bridge of collaboration with populations that have been fearful of research in the world. I think that's one of the areas I'm also very interested in, is how can I help individuals who are fearful of research to feel that they're being included. And that's something that I think that we're really getting better at doing.
Wow. I really like the way you talk about taking the research and bringing it to the population, and doing that through research and some of the design things that we want to talk about. Really starting off is, how are the innovative clinical trial designs being done today, like decentralization, adaptive, pragmatic trials, and how are they reshaping how these new therapies are coming about?
Exactly. This is exciting because now we can develop research protocols in collaborations with communities. We can now bring them on as partners who can help us understand how do we need to show up, not for the patient to come into our clinic, but how can we show up at their home? How can we help see them and capture important data in their home? How can we make that process feel less difficult, because many people struggle with accessing Zoom or getting onto an internet platform. If you're of a certain age, some people, like myself, I'm not a young chick, some people really struggle with these types of devices and getting into a computer and how to best manage this. But if we as researchers can really help ourselves in the design, and I think that's what these adaptive studies are doing, these studies where decentralization, we're really working hard to break through that barrier of logistics, of how do we get a patient engaged and make it easy. That's really the truth of what's happening. And a lot of it is because of these AI systems. In fact, they have developed an AI, what we call a clinical research coordinator called Jane. They're testing someone who is a clinical research coordinator who can actually reach out to patients. So to me, it's exploding, and I'm truly excited to see it. But I think I'm doing a study that looks at the reasons participants engage in research. I have one right now I'm going to be reporting on. And truthfully, we still need to keep that human connection still very present while we're doing research. And I think that's always the fear, that patients feel like, I don't want to feel like I'm just a guinea pig. I don't want to feel like I'm just giving you blood and information, but I really want to feel connected and communicated with in a meaningful way. That's really what's at the essence of these study designs.
Well, I really like the way you talk about the empathy and the customer being the patient. At the end of the day, that's what we're all here for, right? And we can have the greatest technology, but if the patient doesn't use it, doesn't understand how to use it, doesn't know why, we're really not doing justice as a system.
No.
And I'd be remiss not to ask you this question, because this is part of the Women's Tech Initiative in terms of improving diversity and inclusion in these studies for women and diversified populations. How do you think about this as you do research and talk about behavior and symptoms and maybe differences between male and female? And how do you think about that as you do this kind of research?
Well, again, it's starting with the patients themselves. I'm a qualitative researcher, and in order for me to have an understanding of different cultures, different ideas, I do something that's called humility or cultural humility training. You really have to understand who you serve. And I, as a woman who have a background as a Mediterranean individual raised in the South, I have only that kind of perception. I can't step into the shoes of another person's experience except coming with humility. And I think that's what's so needed in the world of scientific research when we're working to find collaboration with diverse patient populations. In fact, I think we need to really reinforce this, because less individuals of women and diverse populations have been included in the past several years in our research. So we need to really move towards this idea of how can we become more collaborative? How can we reach out to the communities and make them partners when we're designing the studies, partners when we're setting up the systems, so that we can come with an understanding of what's truly meaningful for these diverse populations, and not just for a little bit. We really need to have probably this kind of like community advocator that's for the sponsor, who's constantly in touch with the community that we're working to serve and include. Plus, the FDA came out with wanting sponsors to provide critical guides of how they're going to include diverse populations in their pivotal studies and their phase 3 studies. So this is something we need to start working towards very structurally. Personally, that's my opinion.
Yeah, no, that's couldn't agree more. When you think about this, the research in terms of what you're doing, and how do you translate that to like, you clinical care efficiently? What are the strategies to take the research and make it more, I don't want to say practical, but how do we move it to operations? What are the strategies that you kind of employ?
Listen, I hear you with that. I truly do. As someone who did a self-hypnosis study back in 2013, and I still see self-hypnosis not as a critical element that patients can access, is still a challenge because insurers don't cover it, patients don't know where to access it. So the wonderful thing that's starting to happen is implementation studies are being funded so that we can start to understand what do we need to have in place and structurally in place so that this wonderful thing that we've discovered helps people actually gets used. This has been a huge gap in our scientific process. So implementation studies are now becoming sort of that process, just as we do for drugs, as we have this transition, as the drug becomes something that's available on the market. We need to still do that for things that are not just drugs. We need to do it for behavioral support. We need to do it for things that are going to be more comprehensive. Maybe giving, I'm someone who participates in research as a participant all the time. And one of the biggest ways I changed my cardiovascular health was I signed up for a blood pressure registry where they gave me a tool, they gave me a device, they sent me home, but they called me like if I hadn't done my blood pressure, they called me. I felt very cared for, and basically it changed my interaction with how I understood my blood pressure. And I have a big cardiovascular risk in my family. So this was a big deal. We need to do more of that because we're not going to get people to use devices or engage very actively in their health unless we do this kind of implementation to understand the barriers. And I'm so happy to see funding is being directed in this way.
Yeah. Well, it makes sense that that's something you'd get involved with because as a behavioralist psychologist, that those studies sort of resonate. It makes sense to me.
Definitely.
Your perspective on sort of the future, a little bit about cardiovascular disease from a prevention, intervention kind of perspective, because we heard previously today about sort of the after the fact, person has the cardiovascular disease, and we've got these great technology tools that can help with that process in terms of readmissions and things like that. Very innovative. But just curious about your perspective on the holistically from prevention to intervention early on versus sort of after the fact, your perspective from research.
I really love this question that you had proposed talking about because I truthfully believe we don't understand the impact of stress for women, hormonal changes, and how this chronic stress plays a deep role in our cardiovascular health. Is that when we're under constant stress for all types of things, it could be financial stress, it could be traumatic stress, it can be I'm part of a population that is challenged by socioeconomic problems. Stress is truly a huge driving factor for inflammation. And yet we do have tools to help patients and providers who suffer from stress. Because let's face it, I think we're living in some of the most stressful times right now. There is a great deal of challenges coming from many directions. And the more that we can understand how stress plays a role in our behavior, it stops patients from taking their meds. It stops patients from following their diets. It makes patients drink too much. It makes patients smoke too much, do behavior that's not supportive of themselves. So truthfully, if we can truly grasp our hands around stress, chronic stress, and help patients understand how that biologically does drive what's happening to you and your health and your heart, I think we can do a change in the heart health holistically, personally, including more stress processes and biomarkers like cortisol levels and these types of things is truly going to make a difference in our understanding. And I think, as the previous speaker was talking about sleep, let's face it, sleep and stress go right in. You can't go to sleep if you're all stressed out. So truthfully, it's difficult to get good sleep. One of the driving factors of insomnia is that probably your chronic stress. So this is a huge factor that if we can really get some of the things that we can work with for patients into their homes to heighten their awareness of how stress and chronic stress is something that they're suffering from, which I think that's difficult. Awareness of our stress levels is not a simple factor, and that needs to be really a big component, I think, of future cardiovascular health and research.
Yeah, I would agree. I mean, we all have stress in our life. It's really what do we do about it when we recognize we have it. And so
mindfulness, my friend, mindfulness practices.
That's the way to do that. Yeah. So I'm going to kind of leave this. Has just been, we could go on for an hour, and I'm sure people don't want to hear this for an hour, but if you kind of because you're so energetic, I could see it bubbling through the screen here in terms of what you do, just ending, and now Jerry's giving me the high sign, but just anything you want to add, what gets you excited and motivated, the things that you do every day?
Oh, listen, I'm so excited about my new device that's going to be software in a immersive environment, because I believe that if we can truly show a person how they can how they can change their self-perception and include their self-awareness, that we can help them advocate better for their health on a daily way. And I think the software with using, virtual reality tools, I know the things are becoming amazing where you can just have a pair of glasses on and create a virtual to really help a patient create a virtual understanding that they can adopt behaviors that support them and that will help them as they age and help them as they work through their daily challenges. To me, in a very simple way, 10 to 15 minutes. I can't wait, and in fact, I'm modifying my study right now to be more inclusive, because I truly want people to feel like they can be empowered to see themselves differently when it comes to their health.
Well, we're going to leave it there because that's just a great place. At the end of the day, leave it with the patient. They have the knowledge and the power. So Dr. Mary George, thank you for having a conversation.
This was
It's a pleasure meeting with you. And I'm going to turn it back to Jerry.
Definitely, Jerry. Thank you.
No, that's wonderful, Wayne. Thanks so much for this really insightful interview. And Mary Catherine, it's always a pleasure to have you on the program, and good to see you doing so well as well. Okay, wonderful. Well, great chat there, and bring women's health tech also into today's Digital Health Symposium as we go into our second hour of the three. And it's my pleasure to carry on the trend of Heart Health Month and invite Vlasto Hrabal from Cardi AI, again, one of the startups that's now working with HITLAB, based out actually in Europe. So welcome to the program, Vlasto. It's a pleasure to have you on. It's been great working with you these last couple of weeks. Would love to hear more about yourself and what the good work that you guys are doing at Cardi AI.
Hello, hi, and thanks for inviting me. So yeah, we're working together last couple of months and mapping the US market, but we are generally the company from Europe. We're doing the long-term ECG monitoring and detection of the heart arrhythmias. I think we heard a lot of information from the previous panelists about how stress is impacting the cardiovascular health. Yes, one of the output of extreme stress is are also the cardiac arrhythmias, and the cardiac arrhythmias, if they are not detected in early stage, it leads to the stroke, heart failure, or early onset of dementia. So that's what we are trying to detect. That's why we created a solution which is for a long-term monitoring. So it's not for 1 day, 1 week, or 2 weeks. It's for 3, 6, or 12 plus months. So everybody who has our solution at home can monitor your ECG anytime, anywhere, as long as it's needed. And the AI is actually evaluating the heart performance and detecting the heart arrhythmias, evaluating the criticality of the arrhythmias, sending the report to you and to your doctor as well in the same time.
Yeah, and that's super important. It's not just simply just remote patient monitoring now. It really is incorporating AI to change it from just simply monitoring to detection and then prevention as well. And with the work that you guys are doing at Cardi AI and the inclusion and implementation of AI within the platform, how is that technology now of AI reshaping cardiovascular care from, like you said, sort of the episodic sort of 1 day, 2 day diagnostics in clinics to more continuous sort of long-term real-time monitoring for everyday life?
Yeah, so it's not just about creation of the AI model. It's the full process of developing the model, certification of that model, and then putting into the standard flow. So it took us some time to develop the model, but the more work we had was the certification. We have currently the European certification for our AI model, and it took us like more than 3 years to go through all the clinical studies and trials. How we are reshaping the environment. So currently, when you have a cardiovascular problem, you are getting like 24-hour Holter monitoring, or in a better case, you will get like 1 or 2 weeks patch, which you'll put on your body. If you are on the preventive screening, you will get a 30 seconds ECG screen. So these are super short-term monitorings because the cardiac arrhythmias are coming unpredictably and it's very hard to catch them. So it can happen to you that you as a patient have 3 months no arrhythmias at all, and then it come. So this short-term monitoring is based on the clinical studies. The Holter for 24 hours can detect like they have a chance of 5 to 7% of detection of the arrhythmias because of the short time of monitoring. And doctor always have only just this screen, so 24 hours. Then after half year, you have another 24 hours. So generally, the doctors don't see the heart performance in time in, for example, 12 months. What we are changing is that you can use our solution, or we have currently first 3,500 users. So they're using our solution every second day for a couple of hours, around 4 to 5 hours. So during the month, we have around 60, 70 hours of ECG measurement from the average user. And we have it for 12 months. So means we providing to the doctor and to the hospital unique set of data where we are showing the development and the trends in heart performance in time. So we see like how the medication works, what was the post-ablation or post-surgery performance of the heart, if the arrhythmias came back after the surgery, because in 40% of the cases it's coming back, it's just a matter of time when, and it's important to catch it. So That's what we are changing actually, that we providing the whole data set to the doctors, to the hospitals, to see the performance of the heart in context during some longer period of time. And then I think it's important because I personally the case that where I have a couple of months where I have a lot of stress. I have extra 15 kg and the extra systoles, or there are soft arrhythmias, but they are very visible there exactly in that period of time. So when you catch it in early stage, you can just change it based on your lifestyle. So yeah.
No, absolutely. And you talked a little bit about, the communication and the interoperability there between the physicians and the patients and sharing that data. What are the challenges that you're seeing? What are the biggest barriers, especially with clinically validating, AI tools like Cardi AI and cardiology? And how do startups like yourselves build trust, with the physicians and the healthcare systems that that the data and the AI that's being
Yeah.
used is reliable?
So yeah, it's always the hard part of it. But how we approaching it is that when you have the certification, that's the first step actually, to talk to the hospitals, and doctors gain their attention because they know how tough it is to get the certification done in Europe. Second part is that we're doing pilots with the hospitals. So we're providing the system to them for 1-2 months for free. They see how it works. They see what kind of data they can get from the system. They see what is the compliance of the patients or users, that it's pretty high. And then as well, they see the results from the monitoring. So it's standardly happened to us that when we providing this system and solution to the hospitals, they coming back in a couple of weeks that they have so many detections. They were not expecting it, and they actually stopping the pilot and starting discussing the standard contract, to be honest. One additional thing we are preparing this year are the predictive models, because as we have the long-term data of the heart performance of the users, we are actually able to, on anonymized data, prepare the predictive model. So imagine that you will measure 3 months, and then we can predict, like, if you will keep doing what you're doing, how the heart will actually behave, and what is in front of you as a user, and if you will keep doing what you are doing actually.
Yeah, that makes a ton of sense. And you spoke a little bit earlier about, the idea that Cardi AI and other AI-powered cardiovascular tools should really be, starting to be implemented and adopted by, consumers and patients, not just in the hospitals, but also in everyday life, for a much more longer term monitoring, essentially. And how do these tools move beyond sort of the high risk patients to be monitored in hospitals and sort of for the more immediate, and scale more to, to more broader, the broader population?
Yeah, so you're right. Our solution is not directly used in the hospital. It's actually given to the patient, or sold to the patient in the hospital, and he's then taking it home. It's a remote monitoring, so you can have it home. You can do whatever you want during the measurement. It's waterproof. The belt is waterproof. It's a combination of belt and the application. So the belt is waterproof. You can have it 24/7, 365. The battery is there for 10 months, so it's pretty a good system. Then you change the battery for $2 and you can continue. But back to your question, is that our strategy was first to go through the hospitals and doctors, because we are a medically approved solution, to get the credibility of the key opinion leaders of the key hospitals, clinics, that they are using the system and the solution. And then actually we had a strategy to open it to the general public, because the price is actually set up in the way that the general public can afford it and can have it at home and can monitor themselves at home as well, and have all the results of the measurements in their mobile phones, and then share it with any doctor they want. through the PDF report, through WhatsApp or email or any other communication tools. So that's what we opened like a couple of months back. We already have like the share of the distribution channels like 70% through hospitals and 30% directly B2C model. We also launched like the campaigns that the preventive campaigns for cardiovascular health and cardiovascular monitoring, because that's actually what is actually in Europe or in Czech Republic. It's not so common. There are no campaigns as a prevention for cardiovascular health. The only prevention campaign is that you should eat healthy and live healthy. But I think you should also be able to have some monitoring tools where you can check if the heart is working correctly, catch it in early stage, and then the solution for a heart arrhythmia catched in the early stage is much cheaper, easier, and faster than when it will end up with an accident of stroke or heart failure or any other accident. So I think we're doing the preventive campaign in radio, in TV. We are part of a lot of conferences. We have key opinion leaders from the doctors' environment who are promoting the solution as a prevention for the cardiovascular diseases and detection of the heart arrhythmia. So yeah.
No, that's a great way to end the conversation. Vlasto is really putting it simply that the work that you guys are doing is really focused on prevention over cure, which will no doubt save lots of lives, but also save economically as well. So
Exactly. It has a big economical impact from fixing what is already broken to move the money to prevention and even avoid the accident to happen.
Exactly. Well, thank you for all the work you're doing, Vlasto. It's been wonderful to have you on the program. Sorry you didn't have more time to share, but I encourage everybody to connect with Vlasto, learn more about the important work that Cardi AI is doing, and connect with them offline for sure. But thanks so much for coming on, especially in the later part of your day, Vlasto.
Yeah, thank you very much, and it's a pleasure being with you. Thank you.
Yeah, wonderful. And on the note of Lasso joining us in the later part of the day, just a reminder that we'll be holding our Breakthrough Alliance conference in Europe in Paris, March 31st to April 2nd. And we are still always, of course, looking for speakers, and you can go on the website as well that the team has put into the chat to find out more about the event and the speakers and the participants that we'll be having at that conference, which will include, hopefully, Vlasto and some of the other folks you've seen on today's webinar. But we'll move on from patient monitoring devices to now looking at AI and cardiovascular imaging and looking at how AI is enhancing the accuracy, efficiency, and outcomes of especially the diagnostic pieces of imaging. And I'm joined by Dr. Sonia Gupta from Optum, who you'll all be familiar with what Optum does. But Dr. Gupta, I don't think the audience is as familiar with yourself, so we'd love to hear a quick 30-second intro about yourself and what you're currently doing at Optum.
Sure. Thank you so much, Jerry, for having us today. I'm Sonia Gupta. I'm the Chief Medical Officer of the Enterprise Imaging business at Optum, and we have a suite of radiology and cardiology products that are used by hospital systems globally.
No, it's wonderful. Thanks for coming on the program, and we know how busy you are with everything that's going on, at Optum and the work that you're doing as well. So we'd certainly love to dive right into it and hear from you around, how AI and how you guys Optum are using AI to improve the precision of diagnostics, especially, of course, in cardiovascular imaging, and also where have you seen from your perspective the most meaningful impacts on the decision making that are taking place in hospitals?
Yeah, there's a lot of excitement going on with cardiology AI right now, and it's in live clinical use, at many hospitals, and it's making an impact on patients, right now. So it's not just hype, it's actually happening every day. There's two big use cases that have really impacted clinical decision making right now. One of them is AI models being used for plaque analysis. So, the heart is a muscle, it needs blood, and the coronary arteries help get the blood to the heart. And, we know that heart disease can cause blockages. So, enough blood doesn't get to the heart, and that's what contributes to a heart attack. Now, those blockages, cardiac plaque, there's different types, and they can be in different places in the coronary arteries. And so there's AI models that can be used to analyze that plaque. A patient goes and they get a CT scan of their heart with IV contrast. And then a radiologist and a cardiologist and the AI model, all working together, can identify the type of plaque. And, there's hard plaque, there's soft plaque. Soft plaque is actually the most risky and contributes to a lot of heart attacks. And there are AI models that can help detect the severity of that plaque. And so that type of risk assessment, as you can imagine, can make a really big difference in detecting early prevention opportunities. Whether a patient needs lifestyle changes, do they need medication, anti-cholesterol medication? Do they need antihypertensives because their blood pressure is high? Do they actually need a procedure? A cardiac catheterization and a stent, or perhaps surgery. And so that's where these AI models are really making a difference, is that risk stratification, being able to catch problems for patients, before it becomes more critical. And the data is really exciting actually in this space. One study showed that for detecting stenosis, which is narrowing of the coronary arteries, and even risks classification, the accuracy improved by over 20% when you had a radiologist, a cardiologist, and an AI model, over the regular conventional treatment. And the other way that it's impacted patients is these AI-based tools, they've actually led to treatment initiation or intensification in 40 to 45% of patients beyond what our traditional guidelines would have allowed for. So, I mean, as you can imagine, that's a really big impact and a really big opportunity for preventative care that's very exciting.
No, absolutely. And you mentioned a lot of different, you mentioned a lot of different elements there around sort of the physician, along with the AI and all the different, processes and workflows in terms of decision making. And a lot of the settings that we have using, these decision support workflows are usually very high volume. And, where have you seen AI reducing those turnaround times, especially, to help with the burden for radiologists, without compromising the important quality, of course.
Absolutely. The goal is that the AI is focused on administrative and workflow tasks as well. And so that can help improve efficiency and turnaround time. Now, it's really important to note the ultimate goal is not to have the physicians see double the amount of patients in a day. The goal is that when they're taking care of patients, their accuracy is higher. And part of that is also triage. So there's AI models that can help bring critical patients to the top of the list for treatment. And that improves workflow as well. And it brings peace of mind to the physicians because they know that they're taking care of the most critical patients first. And, that's a great workflow example. And another one is there's a lot of repetitive tasks that we participate in, cutting and pasting guidelines for patients that go into, the EHR or the reports that physicians are doing. And so there's AI, large language models that are automating a lot of that process now. The guidelines can be there when we start, and we can just be editing and checking that those guidelines are in the patient care continuum, and they're available to the patient rather than us manually cutting and pasting something, 100 times a day, which is what we've actually been doing.
Yeah, no, of course. I mean, anything to save some time and save some effort and stuff. It's just a natural human compunction to do that. But yeah, some really good insights, Sonia, that you're sharing with us. We really appreciate it. And unfortunately, we don't have all the time to get through all of the different talking points. You can certainly go on for an extra couple of minutes, but I'd certainly love to at least wrap up with you by looking at sort of the outcomes and the value that using AI in cardiovascular imaging is providing to the industry, and beyond efficiency gains, like how should organizations sort of measure the true impact of AI in cardiovascular imaging on patient outcomes, and also, of course, importantly, the cost of care, which I know Optum is very much concerned with as well.
Well, it's really about the patients, and I think it's really important to measure these types of outcomes, of course. So there was one study that actually demonstrated that when using AI-guided risk stratification, it resulted in a 12% reduction in sudden cardiac death. I mean, that is huge when you think about it. So actually, reducing these sudden critical heart attacks with preventative care that's enabled by AI models, that's a huge opportunity for us and a great outcome, that's actually being measured. On the other side of it, there are cost savings as well. As you can imagine, one study demonstrated a cost savings of over $1,000 per patient and millions for a health system, because you were avoiding inpatient treatment, you were avoiding a critical procedure, you were avoiding rehab, right? Because you were getting on the preventative care side, getting into treatment in advance, starting a medication or lifestyle modification before it gets to the point of a critical procedure. So, that's the other side of this, is the cost savings for the hospitals and the patients.
No, absolutely. No, this is, and I think they go hand in hand, really. But Sonia, thanks so much for coming on the program. Again, we know how busy you are, and we really appreciate the insights you shared with us. And I encourage everybody to certainly connect with you, via LinkedIn, and especially look at some of the work that you're doing in the enterprise imaging space with Optum. But Sonia, thanks so much for joining us today.
Thank you so much, Jerry.
Pleasure. Okay, wonderful. And just like that, we are halfway through the February Digital Health Symposium, and I've got the honor of introducing our chair of the Women's Health Tech Initiative, Divya Verma from Accord, who will be conducting an interview and fireside chat with Juliana Berman. Divya, over to you.
Thank you, Jerry. Hello, everyone. Hi, Juliana. It is such a pleasure to see you again. For everyone, I had the honor of meeting Juliana at our annual symposium in December. And so I'm really happy to have you back, and welcome, Juliana.
Thank you, Divya, and good to see you as well. Yeah, and I just quickly introduce myself.
Yes,
so
please.
I came to from digital side to healthcare. I'm not a doctor by education, but I'm a digital person who supports the life science space. And my focus is on connecting business with the patients and the digital capabilities. So customers and patients can get what they need, while digital can continue with innovations.
Yeah, no, thank you, Juliana. And digital is key, and that's the future. So thank you so much. So maybe I can start off with some questions. To start off, Juliana, if you can share, what do you think are some of the biggest challenges in translating hormone-related cardiovascular findings into accessible treatments and clinical guidelines?
Of course. So let me just frame the conversation. Like, we all know that men and women suffer from heart disease, but we also know that men and women might have different symptoms, right? They might have different issues or different reasons. So I'm coming to this conversation from a lens of hormonal changes as woman goes through her life. And a lot of the stages for the woman health that related to hormones, related to pregnancy, to the risk during the pregnancy, or related to menopause or perimenopause, the time that can last 10, 15 years. And recently, more and more researchers started to include that information in the studies. So not only just the factors as what's the blood pressure, what's the cholesterol level, or what's the metabolic issue, but also what's the hormonal stage of the woman that is part of the conversation and part of the study. So the biggest challenge right now is that the hormonal changes are very complicated. They're very complex, and they vary between person to person. Mm-hmm. So it's very hard to put just one set of treatments that can cover everybody. Another challenge is that AI tools, legacy AI tools, were trained on predominantly male data set.
Yep.
So the outcome that they provided were predominantly targeted toward male population and less accounted for specifics of a woman's health.
Yep.
And right now, a lot of studies that do include the hormonal changes, they are still considered observational. We can see the correlation between heart health and the hormonal changes in a woman as woman goes through her life, but we can't really be sure yet because we don't have enough of the length of the studies, enough of years of information, so we can definitely prove there is cause and there is effect. Mm-hmm. And it always takes a lot of time to translate studies and emerging conversations into steady guidelines, especially when we need to update the standards of how we screen people for heart risk and expand the heart risk definition altogether. So there's a lot of challenges we're going through, yes. But yes. It's everything that we can tackle as we go.
Yeah, no, thank you. And yep, so just transitioning from a challenge standpoint to, something that we are doing today, if we dive a little bit deeper into that, what steps do you think are being taken to ensure that new therapies and studies are actually adequately reflecting the sex-specific risk factors and the outcomes?
Yeah, so it's definitely closing the gender gap, right? As I mentioned, that historically most of the participants were males, and the information that we received were according to what we could distinguish in the studies. Now, we did not consider pregnancy state of women, right?
Absolutely.
Pregnancy is a pressure test on the body. Everybody who went through that knows that well.
Yep.
There are also some pregnancy complications that are related excuse me, to hormonal stages.
Yep.
There are some diseases that can appear during the pregnancy and disappear. There is also a menopause timing that in the past were considered as a cliff, the moment the hormones change in woman's body. Now we understand it's more of the decline, and perimenopause can last up to 15 years with gradual changes in hormonal level of women. So all that needs to be accounted in the studies. We also have more and more wearable data that we include in digital tools, and also electronic health record information that cleans from the personal information, but is used in research as well.
Yeah, no, I completely agree. I mean, it's not it's not one point in time, right, when things change. I mean, it's supposed to be tracked. And like you mentioned, your body changes, through pregnancy and after. And all of the information, all of our data needs to be considering different factors, such as pregnancy, menopause, perimenopause. So great point. I have one more question for you, and thank you so much for giving us 10 minutes of your time. Where do you think, I think I know this, but where do you think is the greatest opportunity for breakthrough innovation at the intersection of endocrinology and cardiology over the next decade?
So I definitely think we'll be innovating in the space of detecting the disease early, understanding what causes the disease, and identifying the factors. And different women can have different methods of how they're going to be monitored through life. Depends on the on the history of hormonal changes. So that's definitely something that's in place. I also think shifting from treating the disease itself into preventing it, understanding the symptoms much early in life, can lead to a lot of life saved, can lead to a lot of dollars saved as well, and can lead to a lot of lives that women lead and being more participants in life. And think about the wearables that we all have, always have, all the watch, all the rings, right?
Yep.
And but today, when you go to check your heart, you go to your doctor to do ECG. It's 5 minutes procedure.
Right.
Basically, it's just a snapshot on how your heart works. It's like reading a page of a book and saying you can appreciate the entire book.
Yeah.
So think about wearables that can have ECG taken over a period of time.
Yeah.
That will give much wider picture into your heart health that you can later act on.
Yeah. So just, yeah, no, completely agreed. I mean, we all have these wearables, and it would be amazing for everything to talk to each other, and for our physicians and for ourselves to be able to track everything. So thank you so much, Juliana, for your time, and thank you. We hope to see you again.
Thank you for having me.
Yeah, it's wonderful. Thanks, Divya. Thanks, Juliana, for that wonderful fireside chat. Really, really important topic to cover. I'm glad you're able to make it onto the program to share that with us. And I will now hand the reins over to our own Stan Kochanowski, who opened up the program today. He'll be having a short chat with Dr. Meghna Mittal from Elevance Health. Stan, over to you.
Fantastic, Jerry, and just great to see Juliana and Divya having that conversation, and so many things that we're discussing right now in digital that are changing the way healthcare is being delivered around the country. Next with us, we're really excited to talk to Dr. Meghna Mittal from Elevance Health. And if you could, Meghna, start off with a little bit of your background and your journey in healthcare and global health.
Awesome. Nice to be here, and thank you all for being here. It's great to see the level of engagement around cardiovascular care today. Like many, it's for me also, this is personal, right? So yeah, and I do believe technology has a impact to make. So currently I serve as a senior director of AI and innovation at Elevance Health, where I lead enterprise-wide AI capabilities that support multiple business domains. And in simpler terms, basically I focus on building the foundation that allow AI to scale responsibly by enabling teams with capabilities like evaluation frameworks, guardrails. So we are not just experimenting, but actually deploying solutions that make a difference. So yeah.
And tell us a little bit about your, your view and your vision of how you see digital coming into play for clinical workflows, and where you're seeing AI tools help within the cardiovascular workflows.
Yeah, and I guess in lately we have heard AI sort of get a lot of criticism that for not making into production, and some of that is fair. But also, having been in this industry, having been in this healthcare space, and also working in the AI, I've seen many and deployed many solutions myself in terms of cardiovascular or many other medical care management diseases as well. So yeah, and I think that there are multiple touch points where AI can actually assist providers, improve timeliness of care, where we heard from CardiAI and many other speakers today. Mostly it speaks about, specifically when it comes about the cardiovascular, it's all about the timeliness. It's about the preventive care, management of the disease. So if you map the member journey end to end, AI can support risk prediction, early detection, personalized outreach and education, or prioritization of care management programs, right? Or early signals before any acute events happen, not just there, but also post-treatment follow-up or adherence monitoring. So all of these areas where we have seen the value that AI can bring and digital solutions have been making an impact. So yes, the opportunity is significant.
Great. And we've seen a lot of studies done over the last few months. Last year, there was a study talking about how 99% of AI projects were failing. And this week we saw another one where 80% of AI projects are failing. And so, I think, there's a lot to be said about failure, but there's also, at the lab, we're testing the AI technologies that are coming out every day, literally every day. And so we've got, we usually do about 300 studies a year. We've got about 25 or so up and running right now. When you look at the portfolio of AI initiatives that are happening right now, and especially, you've seen already, I'm sure, a number of them stall after proof of concept. What are some of the key steps that you're seeing are needed to successfully pilot and then scale AI solutions in cardiovascular therapeutic areas?
First of all, I'm excited to see there's an improvement in the number that you quoted from 90% to reducing down to 80. But yeah, I think there are many, especially because the role that I have currently is about scaling the AI solutions. I've seen firsthand where solutions are, falling apart and at what stages. So again, if I have to really draw a mental map around this, there are three stages where I think, or the three reasons why I think these solutions are failing, and maybe understanding the reasons would help us to also understand where we could actually make a difference. So one I see is the system readiness, right? So we're trying to, again, AI can only amplify what already exists. So if care systems are fragmented, poorly defined, AI won't fix them. It will simply scale the inefficiencies, right? So we have to understand the member journey, build a cohesive care model first. We can't just throw AI at the broken system and expect it to just fix everything. So system readiness is one thing. The second I would say is also the talent and process maturity, right? So talent there's no lack of talent. However, the technology is moving so fast that being able to move the talent along with it has also been a challenge. So scaling requires, domain experts, data scientists, clinical leaders. So it's really a true sort of collaborative and very cross-functional team is what we have to build at this point to be able to see an impact. So technology, and I think the third I would say is evaluation and oversight, which is something also I'm very passionate about. That is, even when model work technically, everything works great. Organization often lack clear frameworks to measure impact or monitor bias or meet monitoring requirements and ensure sustainability, right? This is people's lives that we are talking about. So putting these models into production requires real governance and also appropriate, I guess, scaling framework. So again, I think those are if I have to really summarize and create a mental model, those are the three things that I would highlight.
Yeah, that's spot on. Let's dive into that a little bit, because you're part of the Center for AI Testing and Evidence at the lab, one of the 3 centers of excellence at HITLAB. And certainly the chairwoman, Chrysanthi Dory, and again, if the HITLAB production team could put Chrysanthi's LinkedIn address into the chat here, I would recommend that our audience from around the world connect with her and get involved with CATE, which is the abbreviation for the Center for AI Testing and Evidence. But Chrysanthi has talked about ethics as the cornerstone of governance for AI, as we're piloting and building AI platforms to help improve patient outcomes and reduce overall waste and whatnot. And just, I think, what have you seen as some of the better AI governance frameworks, especially some of the more important ones that are around governance, working within the healthcare system so far?
Yeah, so I think like technology governance framework is also trying to catch up, right? So there are many different frameworks that we hear. So again, and traditionally at Elevance Health, we've been working very closely on this governance framework, and I'm outside of Elevance Health as well. I'm very passionate about this framework, and which is why I'm associated with the I guess the CATE as well. And there are many such frameworks, but I would say governance is also evolving. There's no such one framework that I could point to and say this is the golden standard at this point. However, something their NIST framework that we have relied on in the past when we were building our own AI sort of governance framework. But again, it isn't something that you bolt on. I think one principle that I would say as leading the AI teams or building AI solutions is governance is not something that you bolt on at the end. It has to be built in from day one. And honestly, it's hard, right? It's messy. It's not the glamorous part of AI. And if I had to really simplify, I would say There are 4 principles that one has to keep in mind. One is transparency. So clinicians and patients don't need to see the code, but they should be able to understand what type of data and what's driving your recommendation and how the model performs across different platforms or across different populations. Second is continuous monitoring. So again, validation isn't a one-time event. Population change, model drift. We need ongoing tracking and bias evaluation, right? So that's something that is hard work, but important. The third I would also say is human oversight. So AI should be assistive, not authoritative. Again, talking about people's lives. Clinicians must retain the ability to override the recommendations and being accountable for their care decisions because they are the experts at it. Fourth, I would say, is a traceability. You need that auditability of your decisions, how AI influenced the decision. We should be able to explain what data went in, what came out, and what action followed. So at the end of the day, trust isn't built through some kind of a marketing messaging. It's built through transparency, monitoring, and consistency over time. So I would say there's no one such framework. However, across the different frameworks, these are the 4 things I would say has stood out and something that I hold on to as I think about this.
That's fantastic. Well, look, really appreciate you joining us, Dr. Mittal, and looking forward to many more good conversations about AI governance and AI in the ecosystem, and looking forward to having you back on the program soon. Thank you again for your amazing insights and all your good work that you're doing to keep the health system going ethically as we're building AI further into our workflows and our patient platforms. Thank you for joining us today.
Thank you so much, Stan. Yeah.
Just incredible. The kinds of perspectives that we're seeing across the employer, the provider, certainly the health plan, and then obviously the life sciences and communities is just incredible. The government partners as well. Another perspective that we really want to make sure we bring into this is from life sciences. And when people think of life science and they think of AI and just in general informatics and digital health, Alice Chung, who is in the U.S. medical side of Genentech's integrated engagement and process enablement team, and really leading a lot of those efforts at Genentech. Really, she comes to mind. She's been around for a long time doing this work and has been a leader in this area for a long time. Alice, thank you for joining our humble symposium this morning, your time, this afternoon, our time. How are you? And give us a little bit of a 30-second thumbnail on your background and what you do.
Thank you, Stan. Hi, everybody. Thank you for having me. My name is Alice Chung. I am with Genentech's field medical team, focusing on a lot of the integrated enablement and also process improvement. But really, the idea is how do we start to blend the disease states, the patient needs, with emerging technology, process analytics, and program management all together, so you can actually bring the ideas into fruition. That's what I do, and this is an area of passion. So thank you for having me.
No, fantastic. It's certainly an area of passion for us as well at HITLAB. And let's start off the question with just give us the high-level view of how AI and other digital technologies are helping to improve patient enablement around cardiovascular care.
Great questions. And I want to let you know, my response is going to be representing my opinion and not the necessary representation view of the Genentech. And I think, Stan, to your questions, in a lot of research I've done and those I've seen, is like what we're witnessing is a fundamental shift, right? From episodic cardiology to continuous cardiovascular intelligence. So in the past, care happens in moments, office visits, you have hospitalizations, you have acute events. Today, AI and the connected technologies are transforming those moments in a stream of insight. So instead of asking, hey, how's the patient today? The technologies are enabling us to ask, how's the patient trending? What will happen next? Remote monitoring is turning those passive patients into more active patients, and some of the digital platforms, and again, without all the clunkiness of the interoperabilities, are starting to connect physicians from primary care, cardiology, and also home health together. So what we're seeing then is all this emerging technology and the AIs are turning those fragmented data into data points for more continuous streams of intelligence. So the result is not just the coordination, right? It's starting to become more of a cardiovascular monitoring care environment.
That's exactly what we were hoping to hear. That's incredible. And so let's double click on that thought for a moment here. If you could talk a little bit more about what you're seeing specifically within cardiovascular care, which tools or platforms you're seeing really make a difference today.
There are so many tools out there, but I think the most powerful one is not the tools as individual technologies, but it's the ability to connect all the other relevant tools and data to create that intelligence network. For example, wearables are no longer just consumer gadgets, right? They are front lines of diagnostic tools, and they are becoming more and more as a companion diagnostic tools. Remote monitoring is no longer supplementary, right? It is redefining the standard of care in some of the heart failure because you can detect much faster and earlier because you have that constant ways of monitoring data sets to predict. Then AI decision support is no longer optional. It starts to become essential to manage some of this complexity. The real breakthrough to me is how these tools work together. So when you have a wearable detected this earlier atrial fibrillations, right? AI engine can then assess stroke risk. Care team can get alerted in real time. Then the digital platform can engage the patients instantly. So instead of moving from a event base, you're starting to move from detection to action within hours and not months. So hoping that we start to see more of the aggregations of tools coming together to be able to bring better cares for patients.
That's the big step that we're trying to take, and really making sure that all of the work that we're doing, whether it's in digital therapeutics or digital devices or AI powered data insights, are going to lead to overall improved patient outcomes and patient care platforms. I think when you look at all the work you're doing in AI and all the work you're doing in digital, how are you seeing AI powered data insights and remote monitoring complement all the different traditional cardiovascular care workflows that we're seeing out there to help provide more personalized support treatment programs?
Yeah, traditional cardiology is built around averages, right, from a data perspective. I think AI-powered technology can be more tailored to individual needs. So instead of treating as a typical heart failure patient, a physician can treat this heart failure patient with their unique physiology, their genetics, their behavior patterns, and risk trajectory, assuming data are available, to start to bring a much more personalized approach to treat patients. Remote monitoring then extend the clinics into the home, and AI can then translate how some of this raw data is coming together to bring a little more predictive insights. And I think it goes back to my earlier point that all of these tools working together and the capabilities working together is what we need in order to enable this personalized treatment approach. And so imagine we have titrating medications not based on just the periodic labs, but daily physiological responses from your wearables, from your monitoring tools, and that your data set starts to predict, hey, the decompensation days before symptoms appear, so you can kind of, be on the watch out. That will help redefine the care delivery. And obviously, we're not there yet. We are hoping this is going to be the future with a lot of publications that I've also taken a look at. So to be able to solve for interoperability across the tools, across the different fragmented system processes and approach that we have is what we need to get to. And that's what really the data can do for us. That's
great. We have about 1 minute left, and I think let's end this interview with a quick question around what you're seeing in the future. If you want to put your crystal ball or your future medium cap on as the biggest opportunities for digital technologies and AI to improve really the patient experience as well as the clinical outcomes for cardiovascular care. Which platforms do you see in the future really doing this? Is it going to be avatars rather? Do you see robotics coming along? What are some of the bigger digital technologies and AI platforms that you're seeing that can really break this kind of system and really make it better for everybody who is looking for better cardiovascular outcomes?
That's a great question, Stan. So that's my 2 cents. I don't know how technology is going to evolve, but I think the measurable outcome would be to be able to prevent cardiovascular disease before it becomes clinically visible, right? That means prevention. That means teletreatment. That means invisible care, when care surrounds the patients more seamlessly, and also increasing the adherence and improving the trust of all these connected tools, from wearable and remote monitorings, and kind of how care teams are, reaching out to patients proactively. And I would advocate for total health, right, which is the heart failure hospitalizations becomes a rare event. Stroke becomes undiagnosed because AFibs can become less common. And then cardiovascular diseases can be managed proactively and not reactively. And I think this will be the outcome that I'm hoping all the technology, depending on how they evolve, maybe it's a combination of what you talked about, can get us there. So that's what my crystal ball would look like. And, hopefully technology moves faster, that we're able to solve some of this quicker.
Wonderful, Alice. Thank you so much for joining us today. And again, for our audience from around the world, please remember to link in and connect with Alice. She is one of the preeminent leaders in digital health and AI, and just doing a great job. Thank you, Alice, for joining us today.
Thank you for having me.
And as we talk about AI and technology, please remember to join the HITLAB Summit in Europe. So as you know, HITLAB and the Breakthrough Alliance Center of Excellence that we have for startups has expanded to Europe last year, and is doing numerous studies now in European digital health technologies and AI companies. And would love to have you join us. It's going to be, again, March 31st through April 2nd at the oldest hospital in the world, Hotel Dieu, on the island in the Seine, right next to Notre Dame. And again, you'll see from the HITLAB team, people like Laurent van den Berg. He is the chair of HITLAB Breakthrough Alliance Europe. You'll see Bill Taranto, the chair of the Breakthrough Alliance Global Alliance, and many other amazing HITLAB team members, as well as startups and government and executive leaders from the largest healthcare systems in Europe at this very, very nice meeting in this extraordinary venue. Again, looking forward to many other opportunities for you to join us as well as we get to our next speaker, and we continue to talk about data governance and the importance of data in the system when we're talking about cardiovascular care. We're going to be hearing now from Tamer Chowdhury. He is one of the leaders at Boehringer Ingelheim for data governance, and just an extraordinary person who can provide another level of frameworks and another level of opportunity here. Tamer, great to see you. Thank you for joining us today. I'm looking forward to hearing your presentation. If you want to go ahead and share, we'll hand over the virtual podium over to you. Go ahead.
Thank you, Stan. It's a pleasure and a privilege to be here. Just looking for the share button. Just saw it before. Here, share screen. In my mental memory, I always have the share screen in my Teams, which is up on the right corner. Zoom is on the left corner. Okay, so privilege to talk to you all here. And let me just make sure it's maximized. I'm sorry. Okay. Is my screen visible?
It is. You are good to go.
All right, let's start. So I only have 15 minutes and a lot more slides, so I'll be very quick. So the basic idea here is to introduce to you what can we do for our patients to match them to a trial, right? So right now we have clinicaltrials.gov, but we can do better with this emergent technology that we have, not only to build, but also to get AI-generated insights. So meet Sarah in this story. So Sarah is a 67-year-old. She's been diagnosed with paroxysmal, atrial fibrillation, and she's located in New York. That's her condition. She has a CDA-DS VAS score of 3, and her goal is to find a clinical trial that will help Sarah. And what does Sarah do? Like everybody else, like we do, we go to clinicaltrials.gov to find our trial. And Sarah searches for AFib, right, on clinicaltrials.gov. And this is what the scale of the challenge that a patient faces when we're going to clinicaltrials.gov. If we go today and search for AFib, you'll get about 321 studies that are currently ongoing to help. This is one patient, one disease, but we have very zero minimum guidance. First challenge is it's very difficult to surf through those 321 studies and to identify who are the major pharma, maybe that are already in this space that can help Sarah. There's no separation as you scroll through between industry and academic. And also, there is a big dictionary called MESH, which is very difficult when you are searching for your relevant condition. The eligibility text, as I will show you, is a wall of text, which is very difficult for patient to parse. And it's near impossible to go through 321 studies to see which one of these trials is running locally for Sarah in New York City. So this is where we have built an application, or I have built an application, which is, I named it Trial Connect. And this is a clinical trial intelligence that can help us, and we can model this to guide our patients through an AI-powered journey so they can go from the therapeutic area to getting the report and locating the trial that they're looking for. So let's embark on this journey on Sarah, then how this journey would look like. So Sarah would go into this platform and search for AFib. And the first thing that the platform will expose to Sarah is an overview of the cardiovascular diseases and the trials that are currently recruiting. And that's overwhelming if you look at the entire cardiovascular disease landscape, not only talking about AFib, just to give you an idea. So we have several conditions: stroke, heart failure, atrial fibrillation is out there. We have one of the top pharma, starting from Janssen, Novo Nordisk, and Amgen, all working on it. And you have several, sponsors, right, that are working to help this trial. And the enormous, look at the 4 million patients that are currently on clinical trials that are getting treatment. But that's an overview of just your cardiovascular, landscape. Now let's hone down to what we were looking for. So what happens in this particular application is, and this is something that we don't get exposed when we go and search to the clinicaltrials.gov data, is how do we map my search condition AFib, right, to what is available in clinicaltrials.gov for all the sponsors reported condition. So here you can see that we actually have found 41 different variants, what we consider as atrial fib. And also this specific condition that Sarah is looking for, the paroxysmal atrial fibrillation, is specifically mentioned here. So this is all happening of taking that particular AFib and mapping to the MESH dictionary and surfacing from all the sponsors who have reported the conditions that they're treating the trial for to Sarah. Then what actually, just to give you an idea of how the MESH dictionary and everything works, it actually works in 4 different tiers. The first is you have a direct mapping of the sponsors reporting AFib. So you can see there's different way of writing AFib. Someone might write with a dash, someone may write it just with the AF, someone just writing AFib. So what the system does, it takes all those synonyms, right, and maps that to atrial fibrillation. The second one is more of a broader term, which is in the MESH dictionary, one level higher, which are all the terms that are also related to AFib. And then your tier 3 is the related term. And also to remove Sarah from the burden of all the other surrounding disease conditions that are also reported in clinicaltrials.gov, like heart block, coronary artery disease, that are not necessarily related to the AFib condition she's looking for, is also excluded in this. Just to give you an idea of the MESH dictionary of the disease hierarchy and how the sponsor reported term in different nomenclature can be mapped into these 4 tiers. In the next level, just to give you a sample example how the MESH tree would look like. So you will start with your cardiovascular disease, you have upper level heart disease, and the atrial fibrillation, which is the target that we're trying to match to. And also remember, this not only resides on the cardiovascular disease, but if someone has reported under a pathological condition and symptoms, and if that's how the clinical trial has been registered, will also be surfaced. Okay, now, this makes it a little bit easier now for Sarah to pick and choose. So now what we had done is a clear separation that we have 222 sponsors and 321 trials. So how do we surface very quickly to Sarah that these are the three major pharmaceutical companies that she can surf through and choose and pick her trials. So we can see Abbott, Novartis, and Regeneron represented here. And all the other 219s in academia is also clearly bucketed and sponsored and listed for her. So she can also pick, let's say, Tulane University, or maybe she can scroll and pick the Biosense and Region Stockholm. So she puts it in her cart, right? Which are the sponsors that she wants to already work with or offer interest to her. So that's like really a drill down from 220 to identifying the top 3 pharmas and other academia and biotechs that are working on this space just for AFib. Second, what she can do as she has chosen her trial. So for example, Sarah has put in her cart a couple of the Novartis trial and maybe 5 of the Abbott medical device trial, and she can then do a side-by-side comparison. So it's okay, we have Novartis that are doing with 2 drugs, and then we have Abbott that are leading these area with 5 device trials. Going forward, and I only have 4 minutes, so I'll just hurry up a little bit. It's very important for Sarah now to filter out what are the trials that are almost ending, because she can do all the research, but if the trial is already ending, so for example, this one has already ended last month, and this is about to end in February. So then she can exclude and get a clear view on her comparison between the 2 sponsors, and she can always pick any 2 pair at a time to do her comparison. But we think rationally in our human mind, we can only compare a 2x2 pair and proceed in our choices, right? So then that kind of view that kind of gives you the ability to exclude the trials that you want to get out from. Second one is this math view, right? So now that you have honed in on those 3 trials, you can exactly go to each trials at a time, pick up United States, and then pick up the state New York, and here, hola, you can very easily then find that, okay, Weill Cornell Medical Center at the moment is recruiting for one of the Novartis trials. So this is to give you the landscape of the location. The second one that I really want to highlight is it's extremely, extremely difficult for patients and even for researchers when you go through these massive pages of inclusion criteria and exclusion criteria, because there you are basically hitting a wall of text, right? So for a patient like Sarah with a specific NOVS score and specific cutoffs that she has, it's very daunting. And it's not only daunting for Sarah, it's also daunting for clinicians. But we can do better, right, at this age of AI. So what my proposal is, we can also classify into this eligibility into 8 different criteria. So we can bucket them. So we can go to the bucket of age and demographics to understand, what kind of criteria we have, medical conditions, what are the different lab values and tests they're going to do, what are the procedures that are expected, what are the assessments that Sarah is going to go through, what current medications that Sarah is on that is either going to make her eligible.
Hi, Tamer. I think your microphone is off or something happened to your mic. There we go.
Sorry, I just hit this microphone, which is very delicate.
There you go. Now we can hear you.
Okay, I have 2 more minutes. I'll go very fast. So then you can basically go through the different eligibility. You can get the idea over here, right? Just to make it easier for her. Then she can do also research on the drug, right? Which is not available on clinicaltrials.gov. So we can ask AI to say, okay, go to the PubMed and find out, right? What is the most recent publication on glycemate? How does it work? What is the primary indication? What are the key endpoints? So this is empowering Sarah, right? On the eligibility, on the drug, on the mechanism of action that she's working on. So then what Sarah can do, she can create a comprehensive trial report, right? On each of this pharma, each of this trial, on the overview, on the site distribution, on the drug, on the summary, for her to empower her for informed discussion with her physician. So then we can match Sarah, right, according to the eligibility criteria. And then what we really need to do and evolve is look into Sarah's real EHR, health records, which are all reported to ICD-10 codes. So for example, if Sarah has already in her EHR this exact 148 and this particular condition, then Sarah is eligible, right? And then we can already have AI do the patient matching, looking at her EHR record and this particular trial eligibility, and also patients who have a different eligibility, right? Let's say 148.2 is an ICD code. So then they are permanent atrial and they will be excluded from the trial. So this makes easier not only for Sarah, but for a physician to look at the blueprint of the trial is asking versus what her EHR record is saying. And my last slide on time. So this is the AI-powered matching. So what we have already accomplished, that we have a good idea of the mesh vocabulary for matching. We can make the sponsors very clearly available to Sarah. We can do this classification on AI. We can also do the AI, the condition mapping. And we can take this to a next level, right? To really connect with the EHR data and make this trial finding and trial matching much easier for Sarah, and much also so she can get the proper treatment. So this is still a journey in place, and hope this is all for the patients so they are empowered. And thank you for this, Stan. So
thank you, Tamara. It's this phenomenal presentation, and love the framework that you've developed here in terms of having tiers and layers so that it's easier to understand for everybody. And again, thank you for your time in putting this together and for presenting it and this amazing work to the HITLAB audience. And
thank you. Appreciate it. Pleasure.
Wonderful. And so we're really excited to go from one leader to another. And as you know, the HITLAB has a global fellow program and global ambassador program, and Sarian Gruber is one of those, and she has contributed mightily to the thought leadership and the development of the digital health ecosystem over the last couple of decades. Sarian, welcome to the program. And we're waiting for Sarian to join.
Okay.
There we go.
I'm joining.
All right.
Can you see me?
I can. How are you doing? And if you could just start with a small thumbnail 1-minute sketch on your background for the audience.
Well, yes, I have been a member of HITLAB for I guess almost a decade or so, maybe more, and it's been pleasurable and learning and teaming and experience, and I'm very happy to be here, and I'm happy to share with you some of my insights on analytics and data in the cardiovascular space. So. Let me know how would you like to begin?
Yeah, if you could give us a little bit of the work that you've been doing around using advanced analytics to help go beyond kind of simple reporting output and move more into how to turn data into actions for improving cardiovascular outcomes, both at the enterprise level within systems and whatnot, and then also at the real important level, the patient level.
Well, actually, I think I think in my career I have worked with cardiovascular research. When I was at Tenet Health, we were doing a very intensive readmission study, and we were looking at root causes of why readmissions for pneumonia, heart AMI, and heart failure. And we had to go through all the stages and all of the data collection, whereas whether or not it was the nursing home they went to, whether there was a language barrier, whether they were taking their medications, a whole series, as well as insurance that they used and how far away they lived from the hospital. All this data was compiled for a predictive model that also used the Charlson comorbidity scores. And so we actually came out with some very good insights of how workflow was going to be remanaged for Tenet Health. So, and reduce readmissions. So that was one of my first entries into cardiovascular.
Yeah, that's incredible. That's a great case study too. Let's talk a little bit more about some other case studies that we're seeing in terms of aligning, the different stakeholders, whether it's employers or health plans or hospital systems or life science companies, med tech, and the innovations that they're leading right now. And talk a little bit about market research and in the world of innovation, the most important step is just identifying these sorts of companies that are changing, that are moving the needle in patient outcomes and cardiovascular patient needs. How does research play a role in aligning all of these different innovators with real world cardiovascular patient needs?
Well, if you want, I mean, I'm going to use some of your homespun data and programs that I've been becoming learning more about that I think are fascinating, and I'm going to give a shout out to Michael Joseph because I think his products and his projects, Viscelar, about Visceral, I can't even know, I'm sure
Yeah,
how,
Visilier. Yeah, sure.
Viscelier is fantastic. I really do. I think he has accomplished a lot. I think the advanced analytics that he describes are great. He's predicting risk before the disease occurs, early signs, and he's taking the approach of moments that matter with angenic adaptive intelligence and with a clinical AI platform. So I think that will have a tremendous impact and gleaning early data from patients to prevent poor outcomes, so and improve outcomes. So his AI platform includes cardiometabolic disease, clinical patterns. He's also including EMR and EHR data, which is really, really important. More than ever, EHR data has made a very big impact in knowledge and patient care. So that's very good. That's really great that he's using that data, including diagnostics. And another big factor is social determinants of health. And I think that all his information going into this product is going to be have a lot to offer to physicians and to patients.
Couldn't agree with you more. Yeah, we've just so you guys know who are watching at home and in offices and remotely around the world, Visilier is one of the validated AI companies that HITLAB has done a lot of work with, and just seen tremendous use case and growth in what they're doing and how they're delivering it to folks. Let's dive into some of the predictive intelligence that you're seeing as well, Sarian, around cardiovascular care. How are predictive models changing and real world data models changing now that we've got AI and more digital technologies than ever, collecting, disseminating, and digesting digital data, prevention data, treatment pathways, and even things like resource allocation? What are you seeing there?
Um, it's just so much data. The LLMs, the generative and the agentic data, the methodologies are huge. And I think that we're going to make a really big impact. I also am looking at here some of my notes. So cardiology is one of the most data intensive specialties right now for analytic platforms. They can synthesize real-time data imaging, monitoring devices, EHRs, and evidence-based decisions. So the data is coming from many, many sources. I feel that the models are continually to grow, and with the more data, there'll be less biases in what people may hesitate to use these models. So I really feel very strong about that. Um, I would also taking a look at, you mentioned market research. True? Is that an area that you gave me that you asked about
That's correct.
how market research is changing? Well, I
Yeah.
want to tell you something. As of yesterday, it is changed dramatically. Um, Real Chemistry, a pharmaceutical marketing research company that I have been watching for quite some time, have just launched what's called Health Geo. And Real Chemistry was motivated to launch this generative engine optimization tool after began hearing from clients and interested in understanding how patients use LLMs like ChatGPT to gather information about diseases and treatments. Healthcare providers, too, are increasingly using the LLMs in decision making. And Real Chemistry identified an opportunity to go work a GEO into the point of moment for what's important the importance of geo in pharma marketing, and it involves features like LLM, mapping, and daily view into how companies, products, let me get this to my paper here, and therapeutics are represented on AI platforms like ChatGPT, Meta's, Llama, and Claude. So this particular strategy helps identify biases, risks, and misinformations from LLMs about disease states and brand products. Health Geo works by identifying LLM hallucinations early, outdated information, and scam sources. So this tool is for market research. I mean, it helps keep balance, you know, where people might be kind of hesitant, or brands might be wondering, what are my clients, what are my doctors and my patients are looking at when they're looking at data, validating different drugs. And so I really think this was a great, I would recommend everyone taking a look at their product at this point in time and see how it can help in balancing your opinions of what is truly going on from both sides. So I hope that helps you.
It does a lot, and we know that misinformation and certainly any kind of bad information is dangerous, especially when it's shaping people's use of digital technologies when they're doing market research. So great guidelines there. Thank you, Sarianne, for pointing that out. I think another thing that is important, I know in HITLAB's mission of digital and certainly healthcare equity, is around equity and access and using analytics to improve equity in access. Talk to the audience here a little bit more about that and what you're seeing along those lines, how people are using market research and analytics to improve equity and access for patients around the country.
Well, disparities in healthcare is a reality, and we want to make sure that treatments are more democratized so that they reach everybody. I'm going to just go for like one of the newer entries into HITLAB, where I was speaking with Bobby Health, Dave Aris's new program, and it covers several different avenues in terms of monitoring maternal health during pregnancy. But one of the items that registered with me was his monitoring of heart health during pregnancy, which I don't think women really consider to be an issue, but it really is a very big issue. It's a very big issue in low socioeconomic communities. So I just wanted to say that monitoring, then tracking that information really was very. I give him lots of kudos for that in his work going forward.
Yeah, Dave Ezra from Bobby Health is certainly moving the needle as well. You're absolutely right. Thank you for bringing that up again, everyone who's listening to this. That's Bobby Health. They're another validated company at HITLAB, and Dave and his team have put together a phenomenal women's health postpartum depression platform, seeing incredible usage. The number of downloads they're seeing now are thousands every week, and they're seeing it all over the world. So it's not just a US-based platform, but they're seeing it globally in other countries as well. So again, sorry, and thank you for bringing that up. And remember, I think for the audience, AI and digital, when we talk about equity and access, we don't just talk about a specific one symmetrical, very one-dimensional. We're looking at AI and digital improving access and equity on a multi-dimensional layer, right, Sarianne? I mean, whether it's
Yes.
you look at like Pfizer for All, you look at Lilly Direct, you look at a lot of platforms that are allowing patients maybe who are in working 2 jobs, have 3 kids, single parents. They don't have time to go to a doctor's appointment, to go then travel to a pharmacy, and then to go to wherever. They're using telemedicine. They're using virtual care tools now in ways to get antibiotics and vaccines and other really important medicines and other important treatments much more efficiently than ever before. So we're seeing incredible access and improvements in equity just through those platforms alone. To wrap up, Sarianne, let's talk about, we've got about a minute or so left. If you could talk a little bit about the future of data-driven cardiovascular strategies and how that's looking, whether it's the growth of AI, real world evidence, patient generated data. There's so many different things that are improving cardiovascular care through data and AI. And talk a little bit about, for the next minute or so, where do you see this going over the next decade?
I think it's going tremendous. But I also want to say that the patient input from all of the devices that are being administered right now. I think a lot of data will also help in refining these tools to make higher compliance. All these tools and all of these monitoring and treatments is really all based on, I think, success is patient adherence and reevaluating products and reevaluating care as the disease is maintained, is obviously stalled, and better outcomes can be able to be achieved.
And that is a wrap, everybody. You've heard it here from Sarian Gruber, an amazing person, amazing leader in digital health, and a global fellow at HITLAB. Sarian, talk a little bit about the Global Fellow Program and some of the benefits and some of the connections you've made, some of the insights you've gained from being, since you were elected and nominated and joined the Global Fellow Program at the lab.
It has been a great experience. I've been part of a lot of different seminars. I get to meet with some key new innovative companies and really help them and really see where some of their where they need the most assistance or analytics help, things like that. I helped with one of Ellipsis Health at one point with validating their data for their natural language processing for outcomes in mental health. And that was incredible. And then put a paper together for them that was very productive. And I really want to thank everybody on this team. They're amazing. Ash, Ansley, and Jerry, and yourself have all been very warming. And I would encourage many people to come up and come listen to our presentations and get involved.
That's great. Again, thank you, Sarian, for a great presentation today. Looking forward to many more collaborations with you in the future.
Thank you. Thank you very much. Good luck, everybody.
And so we have, obviously, if you want to meet Sarian and the hundreds of other global fellows around the world that are coming to New York City for New York City Health Innovation Week, then please remember to sign up. You can get involved either as a speaker, presenting posters, or just to attend. We'd love to have you join us. We're looking at the New York City Health Innovation Week this year, about 100 different events hosted around New York City, the week of May 4th. And so we'd love to have you join us. Just click on the link there, and we will hopefully see you the first week of May. And next up, we are going from one amazing thought leader on the East Coast to another one in the Midwest, and Dr. Farahani from the Mayo Clinic, professor of medicine, and someone who has been doing extraordinary things in translating innovation into clinical impact. And again, Nazibeth, thank you for joining us today. How are you?
Hi, thanks for having me. So excited about this gathering.
No, really appreciate it. And I think if you could just give a 1-minute profile on yourself to help the audience understand what you're doing in exercise oncology and things like that.
Of course, right from Vive and Health. So we had a gathering, last day, we wrapped it up. So this is Nasibe. I'm an assistant professor of medicine by research at Mayo Clinic, but I'm wearing other hats too. I'm a manager with an Accelerate program in Mayo Clinic platform, which we give access to the identified data to startup companies to develop solutions. Also, I'm a member of Generative AI Committee in Mayo Clinic platform. We need a lot of policies to invest on that. At the same time, I used to be an AI solution developer myself. I advocate for women's health because I'm a woman, yes, and I advocate for trustworthy AI because it falls under umbrella of trustworthy AI. So I'm so happy to be here, such a privilege.
That's great. I believe you have a presentation for us today, correct?
Yes, I do.
Fantastic. All right, I'll hand over the virtual microphone to you for the next 15. Go ahead.
Of course, I'm going to share my screen and so excited to Okay, you see my screen perfectly? Let me just move
It's
the
there.
panel.
Yes, we can see it nicely.
Awesome. Awesome. Thanks for having me. I'm going to talk about translating innovation into clinical impact today. And I know this symposium is focusing on heart health. So I'm going to talk a little bit about the use case that I finished the life cycle of AI development. The question was raised from research, actually. But me and my amazing colleagues, we could have finished the life cycle of developing an AI solution that was not only great, but trustworthy, perfect, and it is currently used at Mayo Clinic by physicians. Here is my QR code if you want to like kind of reach out for certain question. I know it's a fast forward like a kind of presentation, but happy to cover any question through that LinkedIn or any messages. So I want to start with Dr. Berker and tell you why Dr. Berker is a little bit like a kind of different genre of AI. Dr. Berker is a robot that trains to spot the flu. Smart, but only studied pictures of sick boys. So when he, see girls or other patients always said, "You are fine." Trustworthy AI is pretty similar. It's not Dr. Berker is not mean, is not malfunctioning, just, he misses a little bit of good data. Don't forget about that analogy. I go back to that, in the middle of the presentation. I'm going to talk a little bit about definition of responsible AI, why it matters, why we care about that. And, previous like a kind of speakers also touch base about the importance of that in some aspects. We talk about sources and types of AI bias and impact on patient care. Also, I want to talk a little bit about how you can see this bias through your life cycle. And I finished with my one of the most amazing projects that I had privilege of working on that, which was AI Echo Button. Responsible AI is not a new thing. It's literally designing an AI. You develop and implement some AI. Everyone knows about AI very well, but it's a little bit beyond trend. It has a little bit of commitment, transparency, equity, security. It's a little bit beyond that. So we need to make sure that AI is not technically efficient, but also has some human values inhabited on that. I talk about that in a little bit. This means that creating models that minimizes bias, respect data privacy, and are explainable to their users. I want to highlight that the impact on patient care in trustworthy AI is a must. Why? Sometimes when we talk about ethical AI or ethical risk, people feel like that's just a fancy term. It's not. It is a clinical risk. When you cannot recognize right patient, if your AI cannot recognize boys versus girls, there is a threat, there is a risk for the patient's safety, health, and everything. Also, research allocations become biased and your decisions are delayed. And I can show you even, later, can you save money or not? So leadership is not about deploying more AI. It's about deploying better AI. But how we can understand it's a better AI, which is the focus of current talk. I want to talk a little bit about the sources of AI bias. For the people who are in the call, and I take a peek at the attendance, I saw a couple of friends and like a kind of startups that I have mentored. Welcome. I know you're hands-on, you're already doing that, but let us, kind of repeat our core values. Data has some biases, algorithm has some biases, deployment has some biases too. So from data perspective, data might be incomplete. Remember Dr. Berker, he was missing girls' pictures and couldn't recognize them. So representation matters. Distribution should be complete. Algorithmic bias, sometimes based on the design, based on the model, based on the feature selection that you are doing, you make that bias happen. For example, for like a kind of Dr. Berker, you focus on the just number of visits. Everyone knows men for a little headaches, they go directly to the primary care. For women, not a thing. They wait till the last minute, suffer, then boom. So number of visits is not something that should be featured in their algorithm. So what I might have mentioned is algorithm bias is different genre. Deployment itself is a bias that we need to be very careful. We need to interpret the results of AI in a way that our clinician still be the decision maker. And we should not bias them by like just flashing like wrong, and give them information the way that they really trust on AI more than they're supposed to. So bias is not a data science problem alone. It's a systematic leadership problem. Please consider that it's not just data, not just algorithms, it's also a deployment process too. Take a look at the AI life cycle. In every step of AI development, you need to consider that bias. When you are developing your model, when you are talking about the problem, when you are deploying, every aspect need to be considered. So it's not one-time stop. It's just a commitment. It's like you need to capture that anywhere. So it's not like I did it, I move forward. No. All the time you need to keep observation serious and try to decode that. Let's go back to Dr. Berker number 2.0 and assume that we have made this one upgraded. Let's call it Dr. Berker. Dr. Berker, the original one, trained mostly in boys. What about it is trained in all genders and backgrounds? Assume it is biased toward high income patients. I don't know, these boys are like kind of going and they can pay with their private insurances. It could be able to recognize all patients with different type of access. Dr. Berker could have given unclear and flashy alerts with no explanation, but Dr. Berker should be able to talk in plain language, explain why this reason is given. The patient look pale. Number of visits is not an indicator, but we can see the coughing is a symptom, something like that. Dr. Berker, after a while, patients lose their trust and they don't use it and it stays alone. Nobody likes him. But Dr. Berker is respected, trusted by most patients. That's where the importance comes. Let's go to the numbers and see what happens in the numbers. Okay, we know about accuracy, F1 score, positive predictive value. Forget about that. We need to think about misdiagnostic rate too. Also, it brings some, kind of saving for us. When the patients are sicker, they may need to go ICU. They may need more urgent care. So it saves money in long run. Patient trust, this score matters a lot. The more people trust to our AI, the more we can use this ability. Also, it has a lot of return on investment because it has lower risk, better outcome, and overall, the bias has faded away. It is fair for all backgrounds, so it is welcome. I know all of you are asking to give me some resources, some technical resources. There are tons of them. They are coming. One of the best one is Model Card. I'm a member of Coalition Health AI. Please feel free to go download them, use them. Tons of packages, and you can use them as well. Okay, let's go to AI Echo Button. It was a team effort. Me and the other PI of the project worked on that. I wish that he could have joined me as well. Please scan the barcodes if you need to reach out to him as well. So that was a collaborative effort. It took us 4 months to develop the model, 2 years to make it trustworthy. This is about the heart disease. Hypertrophic cardiomyopathy is a genetic disease. They say it's male dominated, it's silent killer, and the patient might pass away because of sudden cardiac death. And if they implant this little device, which is a small shocker, they survive. So, but to be recognized that they are eligible for this, they need to first diagnose this patient. The diagnosis process is so long, takes forever, and we decided to focus on echo. So there were tons of issues that we have with the data. Data was imbalanced. We had mainly patient data, feature disparity. We had different sites. Mayo Clinic has 3 sites, Florida, Arizona, Rochester. A lot of distributions, even workflow was different. The model we were using was adding different biases. So we need to make sure generalize and reduce that bias. Model deployment and development has standard steps. I know all of you more than me know about that, so I'm not going to focus on that, but we finished the general steps of model development. Then we went to the workflow, made sure that we know where we need to have more observation. We need to make sure that we have more transparency, more explanation. We need to know, should it be in EHR, in sonographer's room, in physician room, or in our AI? So we need to figure that out. I know majority of you are asking, how does it look like in practice? Look like this. It's a simple tab in a PAC system, shows a lot of numbers, some recommendation, and we worked so hard to make it in a way that physicians like it. They didn't want that to kind of tell them yes or no. They wanted to know numbers, some suggested measurements, so they can help them to become a decision maker. So we intentionally wanted to keep this human in the loop. So I want to just summarize that responsible AI is just ensuring we have a safe, reliable, fair healthcare. AI is for all patients, not for the ones that we have their data. Their risk need to be mitigated. We need to improve the reliability, and leaders have a lot of impact on that. And we should use current tools, and they are coming. Just stay in loop and try to learn more. If you want to know more about these papers or so, here are a couple of them. More are coming. I have more explanation on that. Happy to have more discussions if you reach out to me, or hopefully those papers can help you to understand about the background. Okay,
That's
hand
amazing.
over to you.
Nazibeth, thank you very much. And a loud round of virtual applause for, again, Dr. Verana, just incredible presentation and great research that you're doing. Looking forward to get you back on, Nazibeth, to hear more about your work later this year. Thank you.
I appreciate your time.
And we are on our last speaker for the day. And we go from one amazing professor to another one amazing doctor to another amazing doctor, from Mayo to Memorial Sloan Kettering. And now we're going to hear from Dr. Jessica Scott. She's the director of exercise oncology at MSK in New York City, and is going to tell us a little bit more about how we're seeing cardiovascular health in cancer survivors really optimized with digital exercise interventions through the MSK program that she's working with. Jessica, thank you for joining the program and handing the virtual stage over to you this time.
Great. Well, thanks so much for the invitation to speak today. I'm excited to share a little bit about our work looking at digital exercise interventions and cardiovascular health in cancer survivors. Why this is such an important issue is that over the past 100 or so years, there's been an increasing number of long-term cancer survivors. And this is really due to increases and improvements in screening and better therapies. So in the 1970s, there were about 3.5 million long-term cancer survivors. But by the year 2040, this number is expected to be over 26 million in the United States alone. And this is fantastic. It means that treatments are working. But one of the challenges that we're starting to see is that there is a dramatically increased risk in heart disease. We know that adult survivors of at least 7 different types of cancers have an elevated risk of heart disease compared to the general population. This is everything from a 4.3-fold higher risk in certain blood cancers, a 2-fold higher risk in breast cancer. So these individuals the greatest risk is not dying from cancer, it's actually heart disease. And why this is happening is what we call multiple hit-induced multi-system toxicity. And this is where at diagnosis, a patient may have multiple risk factors or multiple hits. At diagnosis, this may include obesity or age. They are then exposed to a direct hit of either chemotherapy or radiation. And then the third hit is an indirect hit where patients may not feel great while they're receiving treatment, so they become less active and they may gain weight. So collectively, these hits impact virtually every system in the human body, and in particular, the cardiac and the vascular system. Now, before joining Memorial Sloan Kettering, I spent 7 years at Johnson Space Center working with astronauts and doing exercise training on the International Space Station. And it was interesting that there are a lot of analogous hits and toxicities that astronauts and patients face. Not all astronauts are extraordinarily athletic, and the average astronaut is a 49-year-old male with at least one cardiovascular risk factor. They are then exposed to the direct hit of microgravity, which includes a shift of about 2 liters of fluid from the lower body to the chest and the head. They're exposed to radiation. And then, of course, there are no steps of daily living in space, so there's a lot of deconditioning that happens. But the one thing that NASA started in the 1960s was the fact that exercise was mandatory on all spaceflight missions. So that's why I was very surprised. And one of the reasons I joined Memorial Sloan Kettering was the fact that exercise is standard of care for many chronic diseases. It's been done in astronauts for over 50 years, but after a cancer diagnosis, it is not standard of care. And so our program is really designed to generate the evidence to show that exercise is beneficial at offsetting that increased risk of heart disease. But one of the major challenges we faced in the New York area was that patients had to travel into our center to do the supervised exercise training programs. We need very rigorous and supervised sessions, and having a patient travel an hour to do a half-hour exercise session was really not feasible. So in 2019, we started a tele-exercise program where instead of having patients travel to our center, we delivered a treadmill to their homes along with an iPad. And this allowed our supervised sessions where patients would click a Zoom link on the iPad and join with their exercise physiologist, who would tell them exactly what their session or their exercise program was for that day. So we started this in 2019 before COVID, and then rapidly shifted to a fully remote program. And we've done over 25,000 remotely supervised exercise sessions since 2019. The other challenge that we wanted to solve was how can we additionally lower the burden of having patients come into a center for study-based assessments. And again, because we're in more early phase trials and looking at very detailed phenotyping, we had a lot of assessments that required that in-person visiting. And we're looking at how we can address these different layers. The first layer, looking at the behavioral layer, was pretty straightforward with all of the new devices that are now available, where we, in addition to the treadmill and the iPad, we deliver a sleep mat, a scale, a blood pressure cuff, and an activity monitor. And all of that is Bluetooth enabled, and it's streamed directly into our data warehouse at MSK. And this is really valuable for when we're looking at if a patient took a blood pressure assessment or what their activity levels were like, and we can give them a call and remind them if they didn't take one of their measurements. One of the harder challenges was looking at how can we get at those organ levels assessments that are really important when thinking about cardiovascular health. And to address that challenge, we leaned a lot into some of the work I did at Johnson Space Center, where we did teleguided self-assessments in astronauts on the ISS. So essentially, we would have an expert at mission control and the astronauts in space, where they had an ultrasound probe, and we would guide them through acquiring images of the heart and images of the leg, so we could monitor astronaut health while they were in this very extreme environment. So we thought, well, we were doing this in astronauts who are 100 miles above the Earth. Why can't we do this in patients who are 100 miles down the road? So we started developing a teleguided self-assessment program where patients are delivered a handheld ultrasound probe that attaches to a tablet. And with this, they are teleguided through acquiring images of their own hearts. And it's very feasibility based, looking at if we can qualitatively evaluate left ventricular function with either a 4-chamber, 2-chamber, or long axis view. We can remote guide a pulmonary function test with a tape measure, waist to hip ratio, and then with strength, looking at hand grip dynamometer. And with all of these assessments, I'm a little bit biased, but I thought the one that patients would enjoy the most was looking at their own hearts. But the one that patients hands down really, really love is doing hand grip strength. So I think it's really empowering for patients that they're able to do these self-assessments, and it's really helpful in acquiring data for our clinical trials. And the third level was the biometric level. And again, this was a fairly straightforward solution where we can send phlebotomists to patients' homes We can send them a stool kit. All of those samples are collected and then sent back to our institution for analysis. So collectively, what we've enabled is a decentralized digital infrastructure for exercise trials. And again, these are very structured exercise interventions where if a patient is interested in participating, they will do a remote study overview and e-consent. Once the participant is consented, we then start coordination of delivery of the study kit and the treadmill and the remote assessments, which are on a separate day. Once the baseline assessments are complete, we then start our structured exercise program where every session a patient logs in and is given what their prescription is for that day. And at the end of our intervention, we conduct the follow-up baseline assessments and then coordinate extraction of the study kit and treadmill for use for another participant. So that's a very quick overview of our digital infrastructure we're using to deliver exercise. Given the previous talks, we're also very interested in whether AI can be used to guide precision exercise training. I think we all know that one size does not fit all for many different pharmacological interventions, and we're finding that 150 minutes of exercise doesn't work for all patients either. So we're leveraging all of the data that we are collecting through EMR and our digital phenotyping. We're integrating all of that data, and then we're identifying different subgroups of patients that would benefit from either a lower dose of exercise, a higher dose of exercise, or they may need additional adjuncts like a pharmacological or nutrition intervention. So that's a very quick overview of our program at MSK, and I am happy to answer any questions.
It's amazing and just an incredible program. I think really, MSK, we always look to MSK as one of the national leaders in cancer care, and now obviously a national leader in exercise oncology. And I love the term exercise dosing or dosing exercise, which after sitting here for 3 hours and doing this program, I think I need a dose of exercise myself. Again, thank you so much, Jessica, for joining us today. I'm looking forward to seeing you at the HITLAB Summit in New York City Health Innovation Week. Take good care.
Thank you.
So we are wrapping up the last few minutes of the February edition of the HITLAB Symposium. And again, we've learned a lot about cardiovascular care and digital and AI interventions. Don't forget, again, to join us for the HITLAB Summit and New York City Health Innovation Week with over 100 hosted programs around the city. And also join the HITLAB team for the Breakthrough Alliance Europe in March, end of March, in the first couple of days of April. And of course, we always want to make sure that you are joining us again next month for the March Symposium, where we will be celebrating the digital interventions and AI interventions in women's health and femtech. We have a number of phenomenal people, including Wayne Carfin, who's the board member at Emblem Healthcare, the 3 million member HMO in New York City. Dave Ezra, one of the founder of one of the leading women's health tech companies in postpartum depression in Bobby Health. And Tiffany Yu is a principal at 7Wire, really the country's leading digital health venture firm. And then, of course, our own Divya Verma, who is not only a VP of Business Development at Accord Pharma, but also the chairwoman of the Women's Health Tech Initiative. So again, don't forget to join us. And again, a huge thanks to the HITLAB team who put this together every month for you for free. So don't forget to give thanks to Rachel, Ansley, Raymond, Pallavi, Melissa, Jerry, Nico, and Rijo, and join the HITLAB, one of the HITLAB's 3 centers of excellence, either the Breakthrough Alliance, the Center for AI Testing and Evidence, or the Women's Health Tech Initiative. Your $99 a year membership fees for those programs allow us to put this on for free for everyone around the world. And also, as well, does our sponsors, whether it's the Merck Global Health Innovation Fund, Information Media Corporation, Microsoft, FinPartners, and Actual Health Solutions. They have presented this to you as well. Thank you to all those great digital technology companies. And again, good to see you all. Thank you for joining and have a great last couple of days of February. Take good care, everyone.